All right. Hello, everyone. My name is Nicole Tim. I'm the Customer Education Manager for North America. Thank you so much for joining us today for our Advanced Compression Workshop with Guenter Klose. Before we get started, I have a few housekeeping notes for you. So our general flow today is going to be, we're going to do an overview of the case. We'll talk about the garment choices, measuring considerations, and then we'll follow up with a panel discussion and Q&A. Due to the large number of attendees, we have everyone muted. So go ahead and submit your questions for the case we're discussing in the Q&A window as we go. We'll answer as many questions as time allows during the workshop. If we're not able to get to all the questions, our team will provide those answers as a follow-up. The measuring and ordering forms that we're reviewing today are actually located on JOPE's Compression Institute. So that's www.jopescompressioninstitute.com if you need to look any of those up. We are recording this session, so if you need to step away, we are going to automatically send you a link to the recording afterwards. Nothing is needed from you. You'll get that within a week. And this course has been approved for ABC and BOC credits. As a conclusion, like next week with the recording, you will get an agenda, objectives, and a downloadable certificate. So once you've viewed the entire course, you'll be able to download their certificate to submit for CE credits. I think that's everything, Margie. I'll go ahead and hand it over to you.
Thanks, Nicole. I appreciate it. Hi, everybody. I'm Margie Hopkins. I'm the National Clinical Compression Lead with JOPES. And I'm so happy to have everybody on today. We're really excited about our first ever advanced compression webinar with Guenter. Many of you may have attended our advanced LRX classes previously where we were able to do them in person, but we had this idea to do it as a webinar. And we're so excited also to have our Canadian partners with us today as well. So I just want to mention that this is something new that we're trying, but we're actually hoping to continue this throughout 2021. So we have some very interesting case studies we're going to look at today. If you happen to have case studies that you think might be of interest to us going forward in 2021, please send them or reach out to your medical advisor. We would love to collect these and make this something that's that we repeat at some point in 2021. So that it's like a study group where we can look at these case studies and learn from them. But let's get started with today. And today with us, of course, we have Guenter Klose, and Guenter is the Executive Director of Klose Training. And I'm sure many of you know him. Guenter is a lymphedema expert, and I am so honored to have him here with us today. So Guenter, I'm going to turn it over to you and get us started.
Well, thank you, Margie, and Nicole, of course, for the introduction. This is exciting because, as Margie was saying, this is really the first advanced compression workshop that we're doing online. We have done it so many times in the classroom, in different settings. And I think, the biggest bonus or learning experience that we get from these advanced courses is to listen to patients, hear their story. And we were fortunate enough to compile a little information and a little story about each of the individuals that you will be seeing here this afternoon. And I really want to, make at least one note to SD JOPES and say thank you for incorporating the patients who are not easy to fit, because if it were an easy task every single time, maybe we wouldn't have the need for workshops like this. But, the commitment to serve patients who are not just easy to fit, but also the more complicated patients is really commendable. And I really want to say to the therapists who are listening in and watching this afternoon that there is a tremendous learning experience with each of those patients that we have interviewed. And it wouldn't be the same if they had declined our invitation to participate. there's a really good learning experience, not only from the garment fitting perspective, but also from the therapeutic perspective. I'm sure we have a good mixture of therapists and fitters in this workshop here. And just want to, encourage you to pay really good attention to the patient stories. And from there, we're going to then branch out into the Q&A section, and we'll be answering some questions and also highlight some of the considerations for fitting, which is not always easy with some of the folks that you see in your daily clinic. So with that in mind, I would like to ask Nicole to play the first video. And this first video is of a patient here in Colorado. We watched him going through the treatment last year in May. It was already, in the middle of the pandemic here. That's why we have to work with face masks. But it's a really, really good story from Jordan here. You can learn a lot from him and Vicky, who is his therapist here in Denver, Colorado. And we'll see you on the other end of this video.
At about age 4 was when I first started having the symptoms for the lymphedema, and essentially it started off in just the right leg. It was only in the right leg, and it was just kind of swollen a little bit below the knee. And for a couple of years, we went around to various doctors, and they had no real clue what it was. They had not like really an idea as to far as like diagnosing it or how to treat it or anything like that. Maybe at about 6 or 8 years old, I started seeing Dr. Feldman after someone had seen it at, I think, Barnes Hospital in St. Louis, and they were able to right away knew it was lymphedema. So they put us in touch with Dr. Feldman. And then I believe around the same time I had a lymphangiocintigraphy, and in that one, it showed that the right leg was pretty impaired with the lymphatic flow, and the left leg had still had really good flow at the time. And then when I was maybe about 12 or 13, I was playing some football with some friends, and I sprained my left ankle at the time, and started seeing some very kind of mild. It started off very mild with the swelling in the left leg. And after that, we had another lymphangiocintigraphy done, and at this time, the right leg was showed very, very little flow, if any flow at all. And then the left leg that had the injury started showing that the flow started being very impaired in the left leg as well. So as a kid, I believe in my right leg, I started off with a knee-high garment that I wore for several years, and that would sometimes have swelling that would concentrate in the knee area, as well as the toe area where the garment cut off at. And then after the injury that I had with my left leg, we started getting garments that were including both of the legs, and more of like a pantyhose type per se, that would go all the way up to like the belly button region. I feel like that the other therapists had a pretty good grasp on the stomach and that area of the lymphatic system, but as far as like the legs, I noticed that Vicky uses a lot more pressure in certain areas of the fibrotic tissue. Mm-hmm. And that really seems to take and loosen it up, whereas before those were very stubborn areas that were very troublesome. So like we would do a lot of therapy, but even with all the therapy, wrapping and everything, those areas would still maintain their fibrosis, whereas with the more pressure and whatnot, it seems like it loosens it up quite a bit. It feels more efficient than therapists I've had in the past that just kind of just stand and don't really it's more in the arm with them versus with Vicky. She seems to be putting her weight and her entire body motion into it, and that seems to be more effective like that. I think that's the biggest thing, is the quality of the therapist and the consistency of the therapy and the care.
We found with Jordan that when he started, this was like cement. This lobe, wouldn't you say? It was
Yeah, very,
rounded,
very hard.
and it was as hard as this table.
Yeah.
And that lymphedema is much thicker than just the surface of the skin. It goes down deep, way down. I can feel above the muscle here. It just goes way down deep. And to really attack that deeper under layer, I've been putting pressure, and I'll put pressure. It never hurts you, but it's
maybe mildly uncomfortable, but I understand that in order for the fibrosis to break up, there has to be that pressure in order to get it loose and to break it. So.
And you can even see, I mean, I'm pressing, you can see my fingernails are blanching, but I hold it for about 30 counts, 30 seconds or so, and I can just feel the tissue underneath my fingertips melt away, kind of as if I had my hand on a stick of frozen butter. It just kind of withers away. And then at that point, you can see that difference there. And at that point, I can push that stuff up and get it out of here. And that's why I think we've been able to get, because this is pure lymphedema here.
Yeah.
There's not a muscle in here. So when I get down to this point here, you know, I can take it and either just really squeeze it again. So before I start, I want you to just see how, you know, thick and tight that skin is there. And I'm gonna just take it and I'm squeezing as hard as I can. Sometimes I'll do a plank. I'll put all my body weight onto the limb and hold it. And you can't do it for 10 seconds. You've got to really a sustained 30-second stretch. You'll really feel it, and it really melts underneath. So at that point, you can just see the change that happens in that little bit of time. But I firmly believe that's how we've been able to accomplish as much as we've done in these past 4 weeks. This now being going on to our 5th week, because we've been fairly aggressive at putting pressure in these fibrotic areas. And then I think you've got to take the time, though, then to take this and flush it on up.
Before all this started, I've been largely bedridden and haven't been able to really do a lot of the essential things, such as like grocery shopping or even walking around or doing anything at all. So by and large, this has really just changed my life as far as my mobility, my comfort level, my pain, and everything. So this treatment here has been a lot more consistent. In the past, I have had the CDT therapy. It just hasn't been as aggressive as what we've been attacking it right now at the moment.
Yeah, this is all, if you will, deep tissue, because I've got to break up all the stuff and then MLD. So sometimes, when our first treatments or so, there was no skin stretch at all in the skin. So I had to really break it all up and then do the MLD. We do 90 minutes, and part of that, I'm able to wrap quickly, and I think that's to our advantage that we can do both legs, wrap both legs in about a half hour.
Lymphedema as a disease definitely feels very isolating at times, as far as I used to be very active. I used to play a lot of sports, and over the years it's severely taken away from the activities and the leisure that I can do on either a daily basis, or just even like before I had this therapy, it just wasn't even an option at all to do a lot of the things that I had done in the past.
So every day it's just so much fun when Jordan turns over or something. I mean, just to see this skin that when he first started was thick like a donut, a hard ring around your ankle, and now we're looking at just this nice loose skin. It's pretty fascinating.
With the foam, it seems like it's even though it looks a little bit bulkier, it doesn't have quite the same discomfort as just wrapping directly over the cotton. It is a little bit more comfortable, as well as it provides a little bit more of a squeeze per se, and a little more compression on both of the legs. It's a lot more comfortable than just wrapping over the cotton or the gauze or anything like that. It stays on very well. Yeah, I actually went on a several mile walk yesterday, and it stayed on and was comfortable, and felt like it gave me good compression throughout the entire day, even though I was up walking around on it.
And at this point, I'm just gonna almost done, but this is where he gets a lot of swelling on this leg, so.
As crazy as it sounds, it feels more comfortable like walking around with the bandages, like even with these bandages on, versus if I didn't have anything at all. It would almost feel like I could feel my legs filling back up in that short amount of time of just walking with no compression.
Mm.
Alright, cool.
Cool.
Thank you, Vicky.
So you can just, and we're done.
This year is going to be, I think, my big year with getting the rest of my treatment and therapy and stuff, and then after that, it's just kind of onward and wherever life takes me.
Yeah, no, this is cool. How have you been able to kind of like maintain what you have accomplished with Vicky so far?
So I've actually had a really easy job or really easy time keeping everything where Vicky ordered me, which I have 2 of those. So the two garments really helps out a lot, because then that still gives me time to where I can wash the garments and just allow them to dry without having to go without it. So I have the 2 compression garments that I have with the knee highs on both of those, and I wear those during the day. I've got the garments that I wear at nighttime, and then I also have the Flexi Touch pump, which I use 1 or 2 times a day usually. So.
And so the size you feel has maintained pretty well?
I feel like the size has maintained very well. So my legs, the swelling in my legs has been pretty decent, but the problem area kind of at the moment has been my stomach and groin, where it moves up and it just takes a little bit longer to fully like disperse itself to get out of the rest of my body. I've been going to some therapy here in Pueblo 1 day a week is all I can get in, which it does seem to kind of help, but it's not the volume really to get the upper body moving like it should be going.
Right. Are you doing a lot of breathing exercise?
Yeah, so like when I will be sitting on the couch and stuff, I'll do the deep breathing with like the abdominal compressions. I also will do the breathing with the pump as well. When I'm doing the abdomen area, I'll breathe along with the pump, and when the pump's inflating, I'll inhale or exhale, whatever. So
those garments, I mean, they're not too difficult. I mean, you're strong. They're not too difficult.
no, it takes me 5 minutes to get them on in the morning. I use that little green. It's like a little parachute sleeve. And I just put that on my foot, and then it goes right in. It's really easy to take it on, take it off. So it's not an inconvenience at all. I actually really like wearing these garments because it gives me good compression in the legs and also the groin and stomach area. It provides good compression. And I feel like if I'm not wearing it, I feel like that I feel like I have more fatigue. Like I don't have the energy if I have the good compression on my legs and my stomach and whatnot.
Do you have toe caps too?
I do have, I've got the toe caps as well.
Cool.
That's the only trouble areas sometimes is the toe caps. There's a pressure point, and it's on the pinky side of both of my toes, kind of where the pinky and the foot kind of meet there at the side. sometimes at the end of the day that gets a little bit sore just because it's kind of feels like there's a lot of pressure in that area. But other than that, the garment feels great though. It's very, very comfortable. It works really well. So
I hope you enjoyed this little video introduction of this particular case. Jordan, just as an update, we are now about 10 months after his first episode of care. And I want to make a couple of comments before we start talking about the measuring, because Margie was eventually helping Vicky to measure Jordan in the clinic, like about 9.5, 10 months ago when he finished his first treatment. But the learning experience here for the therapists particularly is that, you know, his fibrosis management was so well done, and therapists tend to be afraid of going at it when, you know, there's a lot of fibrosis. You need to actually work with much stronger techniques, similar to what Vicky has shown you in the video. And that really made an enormous difference in Jordan's case. And I've just saw him last Thursday, so not even a week ago, and he's doing exceptionally well. Now, the other learning experience here is that Jordan was introduced to Vicky by myself. I got involved in his case through Dr. Feldman. And then we needed to wait about 3, maybe even 4 months before Jordan was actually going into therapy and see Vicky, because we wanted to make sure that he would have therapy 5 times a week. This is not the case where you can actually make a huge dent into the person's condition when you see them once or twice a week. So that is really also another learning experience. Jordan is doing exceptionally well, has lost most of the fibrosis. But I want to, now chime in with Margie and see what her measuring considerations were when she saw him. I'm wondering if we should do some Q&A first or go into the measuring considerations.
Why don't we do some Q&A, Guenter? There were a few questions on the therapy.
Sure.
And Sophia, I know you've been monitoring the Q&A, so if you don't mind, thank you.
Yes. So the first question, is the 90 minutes all the massage or inclusive of wrapping time as well?
No, that was inclusive of the wrapping time, and I actually timed Vicky, and Vicky has it down. She could wrap both lower extremity in 28 minutes. That is, of course, the foam was already cut. She had her supplies rolled up and all this was prepared, but she wrapped both lower extremities the way you saw it here in 28 minutes. And then, of course, the other time was spent mainly for MLD and fibrosis management.
The next question, did you start with a compress first before the gray foam?
No, actually, in this case, it was mainly gray foam. There was on the other side it was his right leg. On his right leg, eventually, Vicky used the spaghetti foam, which I'm sure most of you know. So we have an uneven surface that it really helps to break up the fibrosis and maintain what she had accomplished through the MLD. But it was, you need to change it as the situation changes. Sometimes including an uneven surface, even if you have a homemade chip foam bag that you can put into the bandage underneath the gray foam would actually help to soften.
Another question, was he taught self-bandaging or is that not a great option for him?
For him, it would be a great option because he's flexible. He's not only strong, but he's also flexible and he can reach his feet very easily. You could see how thin he is. But it was really, the self-bandaging wasn't really necessary. I am quite sure if we now had Jordan here on the call, we could ask him, he would actually put a bandage over his Alvarez garment during the day. Maybe that's another point that we need to make in his case, because Jobst is coming out, SD Jobst is coming out with different quality garments. They have a place in therapy, the traditional Alvarez Soft, now the Confidence garment, but Jordan's condition, hands down, without thinking about it, is a traditional Alvarez choice. So, and I'm sure he's putting sometimes an additional bandage. I know he also had a ferro wrap that he occasionally puts over his lower extremity to the knee.
If there is significant drainage, do some of the wrap's foam products contain any antimicrobial agents?
No, not really. None of the bandage materials that we use, I mean, first of all, they are latex free, so none of these materials have latex, but they are non-sterile. I mean, the foam that we use, it's usually an upholstery foam. You could get it in your upholstery shop in town. No, it doesn't really. And that is an issue for some people, but if you had someone with oozing, with leakage, with any kind of like that, you would have to put an ABD pad between, that area that leaks. You may have to work with wound care products before you start bandaging, but no, these are non-sterile, not necessarily antimicrobial properties that we use in our bandage materials.
Another question is, with his CDT treatment, was it covered by his insurance 5 days a week? And did he have coverage for the custom garments? So many patients need custom garments to maintain this reduction and have no coverage in PA.
Right. So that's interesting because we are now talking about Colorado. Colorado may be different from the next state. He was on Medicaid last year. Exactly, Medicaid, but Medicaid covered his visits and all the garments. So that is true for Colorado. That may not be true for the next state over. Medicaid is a state-run program where now he's on commercial insurance because he's also hoping to get maybe a surgical consult and maybe some surgery. But I looked at him last week and I was absolutely not really sure why he would even need to go that route. I mean, last year, when he finished the visits with Vicky, I thought that, yes, he would have a point. There was still a little bit of residual fibrosis and redundant skin. We didn't talk about his scrotal edema in this piece because he also has genital lymphedema. But now, having looked at him last week, I'm going like, I don't know why he needed to switch to commercial insurance because I don't see the need for any such intervention. But the other thing is a garment cost. I was just talking to a group of my students this morning, and it is really imperative that not only people need to understand why we're doing the flat knit garments because they are offering the containment the person needs. And you have to really look closely where the patient's potential resources are: family, church, GoFundMe. I mean, there are opportunities where people can raise money for their garments. And that's a reality here in the States. Now we're adding COVID, that adds another layer to the complexity of everything. But really make the patient understand that this is a prescription item. And if you try to control someone like Jordan with an off-the-shelf garment, it will never replace the quality that you get from, let's say, an Alvarez garment in his case.
Guenter, someone had mentioned exactly what you just mentioned a couple minutes ago, that it looked like he had genital edema. Was he also instructed to self-bandage that edema?
Not initially. That was actually something that I tackled with Vicky. Vicky is his primary therapist. I'm not part of UC Health, but occasionally I pay a visit to the clinic. And that was initially not completely avoided, but we didn't make it a priority because the priority last year in May had to be his lower extremity. And this year we actually tackled, I was bandaging his scrotal edema last week. It went very well. Of course, this week I'm hoping to go down to Denver for a follow-up. You have to prioritize, even though the scrotal edema is proximal and essentially should have been tackled first because you always want to evacuate from the top down. But it wasn't made a priority. He did really well. Now it's time to tackle this piece.
Right
So
now,
I would,
I think we're going to jump over to the presentation. We have lots of questions about the garments themselves and the compression class. So Margie, can you explain and Guenter explain the measuring process and
Sure.
what the patient is in?
Yeah, and I'm going to share my screen, Sophia. So let me get this up so everybody can see. Why isn't it going? Okay, here we go. So as you can see, here's Jordan in his garment. And we did, take some considerations, and he did mention he does have the toe caps. You can see them in this picture. He actually has knee highs. He wears over the toe caps and the capris as well. So you can see in the far right picture that he has everything on in that one. And when we measured Jordan, obviously he's fairly thin, as Guenter mentioned. He's not a very large, but his legs have some unusual contours, at least when I saw him. I'm so happy to see those newer pictures that you had, Guenter, and his progress is really amazing. So, these were when I originally measured him. So you can see there were some still really fibrotic areas, and that overlapping also helps it. Jordan himself said he feels so much better when he's bandaged and when he has the compression on. It's so much more comfortable for him. So the layering also helps with that. And Guenter, I don't know if you have anything to add to that. Oh, you're muted. You're muted.
couldn't see, I knew I shouldn't have done that. But anyway, I think in Jordan's case, if you fast forward a little bit to that picture with the arrow that you have after the measuring forms, these are potential difficult areas. And again, he's doing so much better now, but that was the reality last May or beginning of June when Margie measured him. Where those arrows are, these are potential problem areas because one, he does need the toe caps. There's no way around toe caps because even if we did a full foot garment, the full foot garment would not protect his toes. It would cover the foot, but it would not protect his toes. So, and that little dorsal swelling that he still has, which is now almost completely gone on his right leg, needed to be controlled with a toe cap. And one little trick here, if you don't have a patient like Jordan, Jordan is a little bit of an exception because he's young, he is flexible, he can reach down pretty easily, and he can make things work for him. But when you don't have this kind of like flexibility in your patient, choose your toe cap. And Margie, please contradict if I'm not correct here. But choose your toe cap in a class 1 at first. You will, these garments, unfortunately for the patient, won't last forever. So they need to replace them, but get started with a class 1. In a Jordan case, I would probably say it's okay to start with a class 2 because he feels actually better with the compression than without the compression. But in most cases, just to get the person eased into the compression on the toes, start your toe cap in a class 1. I don't know for sure what it was for Jordan, but he would have probably been okay with a class 2. The other measuring difficulties that you have is that B measurement because of the transition, the CY, the circumference Y. You need to take, and Margie, again, I'm going to ask your opinion there too, but I think you need to be reasonable with the amount of tension on the CY measurement. And I can't show you here as my mouse or cursor, but maybe we can point that out in the measuring form. If you go back, oh yeah, see that? If you go back to the measuring form, yes, we can see yours. Now, Margie, how did you accommodate for that transition? If you go back one more, for that circumference Y measurement. How did you account for that?
Yeah, so in a patient like Jordan, I definitely and I just want to say, I helped with this measurement, and I actually took it, but Vicky is actually a very experienced fitter. It's never bad to ask for another set of eyes, which is what Vicky wanted me to come in and take a look, and just any suggestions that I had. But yes, this area here, we need to take the tape up when they're in dorsiflexion. We need to capture some of this area and come a little proximal on the leg there.
Right.
And to avoid any of these creases. So when I'm trying to take even the B measurement, I need to come out, and I stayed right here, where I could kind of capture that little fold that we have instead of going into the crease. Same thing
Right.
with B1, we have this area back here, so you can see even on the B, there's, some very unusual contours because he has, these very fibrotic lobes that are more in the, posterior. You can't really see here in the front. So, you have to really look at the patient when you're laying your tape down to make sure you're not getting caught in one of these creases, so that
And I think that's a really,
stuff. Yeah.
yeah, I think that's a really important learning experience, even though anatomically your measurement would be right at that crease or at that, we sometimes call it a shelf. Anatomically, maybe that's a B or B1 point, but don't take it in the crease because that would be an unrealistic measurement. At the same time, when you look at Jordan's legs here with still a significant amount of fibrosis, you have to then be a little bit more forceful with your measurement over the fibrotic area, because a patient like Jordan, who is very compliant, will actually decrease in that area. So you want to take a good measurement over the lobes, but not in the crease ever. And like Margie said, with the circumference Y, you need to not only have the dorsiflexion in his case, but actually take maybe a little bit extra or a little bit of that skin from that drapes down proximally, that skin what Margie is pointing to down. And then one other thing that, could conceivably be misunderstood when Jobst is using the word capri. I think at one point we probably need to change that, because it's more like a legging. It's not a fashion capri. Your fashion capri starts about halfway up your calf, maybe even like a little bit higher than that. When we talk about capri, Alvarez or capri type, any kind of like compression garment, it is actually more like a legging. And sometimes when I measure for a capri, the distance between the floor and the B measurement maybe even shorter than what I would normally take for that length B. Length B is almost always like 10, maybe 11 centimeters from the floor. In a capri type garment, again, it should be called legging, but in a capri type garment, you want to have that maybe 6 or 7 centimeters, which is, you would think it's not realistic, but there is a little bit of longitudinal stretch in these garments when they come out of the box or the bag. They are short anyway. So you kind of like need to really go low with your B length B for the capri type garment, or let's call it a legging right now. And then any other considerations along the leg? Because I want to spend a couple minutes also on his groin measurement.
Yeah, I just want to point out, so if you have kind of this swelling on the dorsum of the foot, this is another area where I put some pressure in the tape. As Guenter mentioned, we're hoping that goes down when we're taking those measurements. So you really want to put a lot of tension, both on the fibrotic areas and areas like this where we normally wouldn't really pull very tight on the A. I do put more tension when I have this type of swelling. So just tension needs to be a concern all the way up the limb when you're dealing with somebody with fibrosis and, still that stubborn swelling in the dorsum.
Now, Margie, can you fast forward to the toe cap form? Oh, you're a little bit too
there
far.
we are.
Here we are. Now, Jordan complained about pressure on the lateral side where the little toe kind of like meets the foot, he said. And in that case, I just wanted to reiterate, you do need in the Alvarix Plus for the foot cap, you do need a circumference for the pinky toe, even though the pinky toe is not covered in the foot cap. You didn't see that, you didn't see that toe being covered. So the pinky toe, the fifth digit is almost always out. But you do need to have a proximal circumference for that toe. And then if you look on the top of the screen where it says small toe open, you can recess that. And I would recommend at least 1 centimeter. In Jordan's case now, I would go to 1.5 centimeters if he had a complaint about pressure points on the lateral side. Does that make sense? And then if you go one step further, Margie, because I want to go to the genital measurement here.
2-minute warning. Sure. 2-minute warning.
Okay.
Okay.
Okay. So if you have a gentleman like Jordan, now Jordan is lucky enough to be slender. He doesn't have that draping belly over his genital area. But in this case, where somebody even noticed the bulge in his pants, so to speak, you want to take a side-by-side and maybe a front-to-back measurement. When you take the front-to-back measurement for the garment company for the flat knit production, you actually want to go and do a front-to-back measurement from beneath the penis all the way to the back to the perineum. And then it would give you, I don't know if you can see that here in the little picture on the side, but then you can actually build a little bit of a pouch. Now, depending on the overall measurement and the dimension and how it relates to everything, the company may not use those measurements. But in Jordan, it would have been a good idea to take this into the consideration for building the crotch in that garment. Does that make sense to you, Margie?
Oh, yeah, absolutely. I think moving forward, Jordan could benefit from having something like that in his garments. And since we are talking, I did want to mention, Jordan does have a Jovi genital pad to wear at night to give him some extra compression as well in the genital area. And it's something Vicki and I talked a little bit about when I was there, but as you mentioned, initially it was really his legs were the first consideration, but I agree, as he goes forward, that's definitely an area that he can use some work on as well.
Okay. All right. Sophia, I know that you have been monitoring the questions, and I would say we can take 1 or 2 more minutes, but is there any pressing question, anything that sticks out? 5 people had the same question.
Oh.
You do have to unmute yourself. Oh,
no, there you go. We can't hear you now.
Sorry.
There's
not any pressing questions at the moment.
Okay.
We have a lot of interest in the question and answers. So if we didn't get to your questions, we will get to them later on. So we will send out answers to those questions.
Okay, cool.
Right.
I mean, this has been a good case. I hope you learned a lot. Margie, is there anything last comments for this case before we dive into the next?
The only thing I can think of is that, everything's a work in progress, right? And I think Jordan's a great example of that he continues to go back and see Vicki and make great progress. And, his garments and his compression get adjusted as he moves forward. So I always like to mention that it's not always, this is what you're going to have for the rest of your life. But I'm happy to see him doing as well as he is. So thanks for the update.
Margie, before we move on, did you mention what were the class of compressions for the knee highs and the leggings?
So I believe he was in
So I will find back.
3 Forte knee highs. And then I believe we did class 3 in both legs and then a 2 in the panty portion, just to make it easier. You could see how high this goes up. That's due to he has some abdominal swelling as well.
Yeah.
And then, of course, I do believe that we did do a class 1 in the toe caps. I agree with Guenter. I think when you're getting somebody used to wearing toe caps, class 1 is a good place to start.
Okay, very cool. And hands down, this is an Alvarez patient, so you would not have to think about, is that a soft or is it a confidence? That is definitely, the decision is pretty clear in his case. So now we're going to move on to another interesting case. I'm very excited about this case. I'm super excited because there's such a learning experience in this case. Now, Margie, if you stop your screen share for a moment and have Nicole play the video, I hope everyone can see Bridget's story.
So she came 2 weeks ago for an eval, and all of her surgeries, the cancer has always been on the right side. And 2008, she had a lumpectomy and radiation on the right side. And then just this past year, she was diagnosed again, same thing on the right side. They took a sentinel node biopsy, both were negative.
So on December 16th, I had a double mastectomy. Post-surgically, I had quite a bit of swelling afterwards. I'd had 2 surgical drains, 4 surgical drains. 2 of them were removed after 2 weeks. The other 2 stayed in an additional week.
But she was experiencing heaviness and discomfort bilaterally, both arms. And when I measured her, the left, the non-affected rest side, was 10% larger. And the left side also has a lot more axilla swelling, a little bit more chest. Incision isn't as healed. So we kind of first had the therapy at both sides to see if we could first get her feeling more comfortable and start to initiate some type of manual lymph drainage just to get things moving a little bit better, and then getting into compression. So the first evaluation day, I ordered her light compression for her arms because there's no pitting. There's really, it was just her feeling of heaviness. And even though it's 10% larger, really it was more so just tricep area and kind of here and there, a couple centimeters larger. So it wasn't a significant, definitely lymphedema. So I got her bilateral Jope Spella Light 15 to 20 compression and the gloves as well. Bridget has a history of carpal tunnel and of kind of nerve pins and needles and pins or whatever.
But it's been great since I had surgery. I had surgery, both hands. I had carpal tunnel surgery. I think I'm 7 years now, and I've had no symptoms since the surgery.
So with a little heightened nerve sensitivity, my thought is maybe the gloves a little too tight on the wrist, the overlapping of the glove and the sleeve. So I said yesterday, take off the compression and let's see if it goes away. And how'd you feel?
So yesterday without the compression, I didn't have the tingling in my arms, but my arm felt swollen after my 4 hours of work. And my husband said it looked visibly swollen when he looked at me. So that was without the compression. I did put the compression on later on in the day just to see if it would reduce, and it didn't feel that heaviness associated with the swelling.
Yeah. So I think the sleeves are helpful right now.
Right. How are your hands? Is there any visible swelling in your hand, or can you pick up the skin pretty easily like this?
Yeah, I can pick up the skin pretty easily. They don't seem swollen now. There have been times that they have been very swollen, swollen that I couldn't wear my rings. So I'd dunk my hands in freezing cold water and kind of wiggle those things off. And
Okay.
with the gloves, I couldn't wear the rings, so I just took them all off.
There is seroma here on the left side, right? On the right, is it? No, the left side has a seroma. Is that starting to resolve, or is it still a big problem?
So the first day I got her the pad, the Jobst mastectomy pad. So she wore that, but it really didn't. So when we were a different size is coming in the mail. I got her a large, but I think the medium is better. So when she puts it on, it's not really addressing right
Up
here.
Right.
So I had her try to flip it around so that it
And then
came
it
up
was
higher.
Kind of digging,
You're right.
Yeah.
and sliding down
So
because
I think
it's the wrong size.
I think the medium will be better. So, and then also Bridget is really smart. She took kinesio tape and basically lifted up the seroma,
Right.
so that it wouldn't really lay on the incision, which has been very helpful. And I did some tape that back to the sternal nodes and down to the inguinal nodes with the tape to drain the whole area. So overall, it looks better, but still enlarged. She's now wearing just kind of like a tighter compression, but we have a compression bra coming in the mail too. And I wonder if that's going to give more coverage for the compression. And I also made her, you want to show them, I've been making all kinds of stuff.
Yes.
This, I made, so that goes basically here, and then we really press there. And then there's also little foam pads. We've got a bunch of things here. We try everything.
Oh, hold the fell off.
So just like a little circle compression too.
Right.
So
Okay.
we're on the right path, but.
And do you feel any other truncal swelling besides the one here under your arm?
Around to the back, but I don't feel swollen coming down my sides at all. It just the chest area around to the back.
So it is very balloon-like, the texture. So when I press one area, it ripples, and the fluid I can actually feel move. Not like lymph fluid. It feels like
It's almost like, let me say, like a waterbed.
yes.
That's what I call it, a water balloon.
Exactly.
That's what I call it, my water balloon. It goes. I kept mentioning to the doctor that I had an awful lot of swelling. I'd have what felt like a water balloon under my arms. If I touched the swelling, it rippled like a water balloon does. I don't know how else to describe that. And the doctor kept telling me, no, it's all normal. So when the final drains were removed, I felt some more comfort. I think only because I didn't have something stabbing into me all the time. Something to be said for that. And then, but the swelling didn't really move. It still was there. It was still very uncomfortable. On my tricep, you could see a visible bubble underneath my tricep, maybe even up to a month, 5 weeks after surgery. And I still get that swelling now, that I'll see that my arm is swollen and it looks like I've got a bubble hanging off of my tricep. What I want is I want it all to go away, and I want to feel my chest to be convex and not, concave and not convex. And now I still have some swelling there, and I just, I'm getting a little frustrated that it's not going away as quickly as I'd like to. And I'm trying to be patient. And I am doing everything Barbara has told me to do and more. You know, she told me I could start arm exercises. I'm doing a whole bunch of arm exercises. I am wearing the sleeves, but we talked about that now, and maybe that's not in my best interest at this time.
So I see you're wearing the compression here. So tell us a little bit about what's going on since I saw you last time, which was in the clinic. So what's happening?
So, since you saw me last time, I had been wearing everything that I was fitted for, all kinds of a fancy bra and compression stuff. And the swelling went down an awful lot. On the left side, it was no longer like a water balloon that I could, push it and it rippled. On the right side, it was still rippling. This Tuesday, I went and they drained off 240 mLs from the right side. And since Tuesday, I had been totally compressed with everything I possibly owned. I had,
True.
Barbara saw it, I had so many layers on. My husband said it looked like I was ready to play hockey at any time.
Yeah.
At 4 o'clock this morning, I could take it no more. It all had to come off. And now everything's in the wash. Now I have on just one of the compression things, and that's all. And my chest is flat and there is no rippling or waterbed effect. Since I had been wearing the stuff you gave me, there was the pad that went under the arm and the, was it the Bella Light, Barbara? Bra?
The Belize bra.
Belize, the Belize bra. That helped tremendously with the swelling. And Barbara has measured me and has seen a difference in the swelling that has made.
Okay, let's keep an eye on that. And Barbara, what is your plan for Bridget now going forward?
So last time I saw Bridget was on Wednesday, and I measured her arms for the confidence sleeve. And then Joanne on Saturday is going to measure her for the gloves and is going to do the full scan of her arms. So next time Bridget is in the clinic, I'm going to measure her every 4 centimeters. And then me and Joanne are going to compare to see my measurements versus the actual scan. So that'll be interesting to see the human measurement versus the machine measurement to determine how accurate that we're doing it. And so then she'll get the sleeve and the glove, and then she'll kind of compare to see if the Confidence custom sleeve and glove works better than the Bella Light off the shelf sleeve and glove. So it'll be interesting to see what Bridget thinks is better or what feels better, what's more comfortable. But her swelling continues to go down. She lost about 4% of volume in the left arm. So she was 10% larger. Now she's 6%. And then hopefully, I'm sure it's even down even more now that she's been aspirated and she's been really compliant with all the compression. She's been an awesome patient, so it's really good.
So you feel like you're well taken care of right now?
I feel like I have the dream team on my side.
Yeah, I thank you for this opportunity to hear what's going on.
No, thank you for taking such good care of me and giving me some great devices that have helped. I really appreciate it.
Well, you deserve it.
Thank you.
Thank you.
So I hope everyone had a good learning experience from Bridget. Bridget is an exceptional patient. If anything, she is a little bit of an overachiever. She does more than you ask her to, but Barbara can attest to that better than I can. And I just wanted to reiterate what you've seen in the video, because this is so important and it could help so many patients after breast cancer. Initially, we talked about the seroma in her armpit. The real seroma was actually here in the chest wall. And a lot of women will have to go through aspiration. After aspiration, that means they have a needle puncture. Excuse me, they have a needle puncture and to extract the fluid, and they have to do that 3 or 4 times. Even, we may not have seen this in the video, but even in Bridget's case, I think the surgeon was ready to say, hey, you're going to come back and we'll do that again, maybe 1 or 2 more times. Now, Bridget was so adherent to wearing her chest compression for even more hours than we asked her to. And I think that will keep her from not having to go back and aspirate it again. But Barbara, awesome job. And thank you for, introducing us to this patient. Anything in the video that we didn't cover that was important to you?
Thank you, Guenter, and thank you, Joanne, and thank you for having us. And like you saw, Bridget is so happy, and she really thinks that she truly has the dream team. And I think the biggest takeaway was that immediate compression right after aspiration. I told her 48 hours, she kept it on for 62.
and she really was compliant. And I think that was the biggest key to her not filling back up. And I think that's really what I took away from this experience, and what I hope that the participants watching this will really learn from. And hopefully we can continue to help more patients like Bridget.
So Sophia, what kind of like questions have we had in regard to Bridget's case?
We have a few questions regarding the Belize bra. So individuals didn't realize that you could utilize the Belize bra when the patients have no breasts. Do you want to just expand a little bit on that?
Joanne, I'm going to defer to you on that one. What was your thought process when you first saw Bridget, maybe to recommend the Belize?
Yeah, a lot of people do feel that way, but actually, when you are actually measuring for a Belize, you just use an AB cup. And the AB cup will basically give you enough compression. And when you're using the Belize, in combination, like with an axillary pad that we put in there, because when I first met her, she had a lot of tenderness in the axilla, and she didn't even like the gusseting that's soft in a Belize. What we did is we put the axillary pad in there, and she felt instant comfort. And the axillary pad will cover pretty much, I would say, about a little shy of 50% of the lateral breast area. And usually the majority of cancers are found in the lateral part of the breast, in the superior and inferior quadrants. And so this is a really nice thing to put in right after having a aspiration. In addition to that, we put the unilateral mastectomy pad in there because we needed to have that compression over the major area of the breast and chest wall where that seroma was located. And we layered them. So people would say, well, do you use just one or the other? But we actually layered them. And like I said, she loved all the padding. I mean, and it made her very comfortable. And so that's where the track we took.
Okay, maybe Margie, before we answer more questions, can you pull up, we can still see the panel on the side, but can you pull up that excellent picture of Bridget? So while you're doing this, Sophia, any more questions?
Yes, absolutely. Now, maybe Joanne can answer this one as well. Would a serratus anterior Jovi pack work?
In this case, it would be too small. In some cases, it would work really well, but as you can see in the middle picture, in the top row, she has the unilateral mastectomy pads on each side, and it basically covers all of the territory. It will cover a little bit of the upper quadrant. It won't go up to the clavicle, and it also covers very well in the back once you adjust the straps. So a serratus pad is a little smaller, and there's a slide in here that'll show you a size dimension when you compare sizes.
Now, another question, would this patient be a candidate for a compression vest?
That's Cindy. Where's Cindy?
Okay, maybe we'll bring Cindy on, but let me first introduce Joanne Brooks. Joanne, we didn't get a chance to actually introduce you, but you are the local person up in New England. I think you live in the Boston area.
I do, yes.
And she is with SOD Jobst. So she is Barbara's kind of like go-to person when it comes to measuring lymphedema in that geographical area of the country. So Cindy, are you on too?
I am here.
So and before Cindy starts, I just wanted to say something. Before Cindy starts, when I went to see, Bridget, I actually have had a vest all the time in my sample kit. And I took it out, and when we first looked at it, both Barbara and I go, she's never going to get into this. But we got her into it, and she loved it. I mean, she absolutely loved it. And she said it slims all the places, and she felt very comfortable in it. So I'll give it to Cindy now.
And Cindy would be the equivalent person to Margie and all the other MAs, but in the Baltimore area. So Cindy, what's your takeaway from the vest measurements and stuff?
Well, I use a lot of vests for pretty much any breast surgery because we are focusing on the chest wall. What I usually do, though, is I measure with some capped sleeves so that you can get circumferential compression around the axillary area. And I measure it all the way to the gluteal cleft. so that you get coverage for all 4 watersheds.
And I could just say something. I think that the length of this vest was most important to Bridget, because if you see Bridget above with her vest, she has a bit of a tummy there, and she was so excited to have that completely covered. If it wasn't long enough, you know, it would have caused a lot of discomfort and right up. So I think that was great. And I just want to say, I just had a sleeveless vest, so I take no responsibility for not having sleeves.
No, I completely understand. I love the fact that you at least had this. Another thing that's very important is to also use a 5 centimeter or 2 inch silicone band at the bottom. If you do a 1 inch, it does not work at all. And as you said, Joanne, if she would raise her hands up with a shorter vest, the whole vest would rise up as well.
Right, right.
Definitely. Also, you don't have to have any pockets or pads in this. You just put in your serratus anterior or whatever you need, and it stays in place for you. It can be worn 23 hours a day. So you can put this on and then put your Jovi night garment on to go to sleep, or during the day, you put your sleeve on first and then put the vest on.
But what if, Cindy, what if the patient does have a breast on the other side?
It contours very, very well. And of course, you can always add padding if you need to. We have a lot of different paddings you can put in if it's not getting direct contact.
Okay. Any particular measuring tips? I know, Margie, you have a couple sizing or measuring forms in your PowerPoint presentation. Cindy, because we cannot go through the entire vest measuring, but what is the most crucial kind of like consideration when measuring for a vest like this?
Well, one thing that we've done is we've kind of simplified the order form if it comes up.
I know, sorry. Trying to find it here. There it is.
There we go. So we really simplified it. So we only take the measurements we need. On the old custom seamed form, it was very, very confusing. So the measurements that are important are the left shoulder and right shoulder. When you take those measurements, you want the patient to bring their arm up to a 90-degree angle. Take that circumference around the AC joint and then drop the arm back down again. That will open up the axillary area so it doesn't bite and pinch. Another very important is when you're taking the chest circumference. That is at the axillary line. You bring the arms back up again. Get your measurement. After they drop the arms back down again, you really want to open up that area so that it's much more comfortable. Obviously, don't squish the neck. And I always do a nice firm circumference at the end of the garment. And again, I take it down below the gluteal cleft. So I give that a good tug. And then all the measurements should be taken from the back, because you're not going to follow contour. You want a plumb line from the AC joint to the end of the garment or to whatever you're going. And then we just need arm lengths.
Right.
Okay. And these measurements would be taken in inches, is that correct? Or does it matter for the measurer?
We like it to be done in inches, but if you measure in centimeters, just note that on the order form that these are taken in centimeters, or you'll wind up with a really big vest.
Yeah.
Yeah. Seen it.
Exactly. Joanne, I'm going to go back to the slide with the pads, and actually I'll just go to the valise measuring. Do you mind walking us through really quickly here?
No, not at all.
Valise is ready to wear, so.
Right. So it basically comes in quite a few sizes. It ranges from a 32 AB to a 50 double DE. And that's a wide range really for a lot of patients. For those patients who have a small rib cage but have a large breast, one has to think about, first of all, where that breast sits. So sometimes the error made is they measure the breast in its natural form, and you can't do that. You have to pick the breasts up and make sure that they are front and center in a bra preferably, so that you're able to measure step 2, which is around the nipple line, to make sure the breast and the nipple line is where it would be naturally. So if someone has ptosis of the breast, particularly severe ptosis, you have to bring those breasts up. And then once you get that measurement, then you measure directly underneath, which is sort of like where the inframammary line is. And then the 1B is where the rib cage would be. Now they have here a guideline, 2 inches or less, or 5 centimeters or less. It's an AB cup. But I sometimes have to go a little bit more into the art versus the science, because if someone has a very small rib cage and a very large chest, I will go up a cup size for them because it will work. If you're in between sizes, you have to realize too that there's ways you can actually expand the actual band of the bra by putting in an expander, which has 3 additional settings on it. And so one can look at, say for instance, a bra that has the first hook, if you will, at the bottom. And as you come up, you can fan it out and allow for a larger breast, capacity that will fit them easier. So there's a lot of room to actually work with trying to fit someone perfectly with this. If you're using it almost immediately post-surgical with the pads, you want to basically put the hooks out at the widest part, because after they take the pads out, the bra then can be reduced to the actual skin, because a pad will add at least, an additional 2 inches, maybe 1.5 inches, to the actual circumference. So just things to think about as far as when you're trying to fit people for the Belize. And I just want to say the Belize can be worn 24/7 as well. The bra has 2 layers to it. The inner layer is the compression layer. The outer layer is a non-pilling silk layer. And that silk layer with its band will not crawl up and under the breast, which is one of the biggest problems with a lot of post-surgical bras that are one piece, because they will crawl up just like all of us have women, that is, Guenter, that have worn some of the sport bras that will crawl up and you need to pull it down. So just something to think about.
2-minute warning.
Huh?
Okay.
2-minute warning.
Okay. So no, this is an awesome information. Joanne, go finish your thought.
Oh, okay. So here's the pad. So I just wanted to show you the axillary pad. On Bridget, we went with a small versus a large. And what she had mostly, as you could tell, she had a little bit of overflow of swelling into that axillary area from the sentinel lymph node dissection, which basically creates a pocket, and where there's a pocket, fluid will find a way. And so this was not only helping her with the sensitivity from that, but also giving a little bit of compression to that area as well. And that comes in a small, medium, and a small, medium, and then a medium large. It only comes in 2 sizes. And you can see it in the lower right-hand picture there with all the rest of them. The unilateral mastectomy pad is the pad to the left of that axillary pad. And you can see that it really can cover a great portion of the anterior and posterior chest wall. Whereas the serratus pad, which is the upper right-hand corner, you can see is much smaller in dimension. For a lot of people, they might want to use the lateral pad, which is the one below the serratus anterior pad. And then, of course, the lumpectomy pad is probably the most popular after having a lumpectomy and then radiation, where you have the dermatitis due to the radiation, which then can set off fibrosis, well, most likely will. You can wear this lumpectomy pad, and it comes in small, medium, large, and extra large. And that will help, even if worn at night only, to offset radiation fibrosis.
Okay, thank you, Joanne. And I think we need to just, and I know I'm very much aware of the time, but I'm going to just get a smidge into the break here. We're going to have a break in a moment, but just a tremendous job. First of all, Barbara, thank you so much for introducing us to this patient, and that was a tremendous learning experience. One more thing about seroma and then the subsequent compression after like maybe an aspiration is that the compression really needs to go on after the needle comes out. You cannot wait 5 hours before you compress this area. And I think that's where a lot of people miss the boat. They actually don't compress it at all, which is not working for most people, or they compress it too late. And that wouldn't work. So you have to really more like stand by with the compression in hand. When the needle comes out, that person needs to be compressed. And then like Bridget, a bit of an overachiever, keeping it on for over 60 hours, but you have one compliant patient on your hand. I just want to touch for 1 minute on her sleeves, because initially you put her into the Bella Light, which was a good choice for the moment. Bridget may indeed be one of the candidates where the confident sleeve would really work well for her. We didn't get it in time, so we didn't see that kind of like side-by-side comparison. But for all the audience here, I also want to say that Bridget strikes me as a person who may use arm compression later on. She may not need hand compression. If you don't over-compress her arms where fluid might migrate into her hand, she might indeed be benefiting from arm compression. Custom is always preferred. And I think that she would be a good candidate for a confidence sleeve. And I know, Margie, you had the order form up there, but we'll see if there's any questions. We can maybe chime in later on again or circle back to it. Is there anything that Margie or Barbara want to add to this case? I guess not.
Nothing on my part. Yeah, no, I think I think this is a real success story, and just want to congratulate Barbara and Joanne for kind of teaming together to come up with really great solutions for this patient. She seems very happy with where she's at right now.
Right. And Sophia, was there any pressing question where you say, hey, 5 people had these questions?
Yeah,
we need to get that in.
There sure is, Guenter. There's multiple questions asking very simple.
One more, because I know we have that buffer in our break.
Yes,
one more question.
Absolutely. So there's a lot of interest. Individuals are asking, how do you feel about seroma aspirations versus manual drainage? And is there any research to support for not aspirating seromas, but rather apply immediate compression and MLD?
Well, it's a pretty big question, but if I had to answer it in short, and Barbara, help me out if your experience is now different. When you have this kind of like seroma, which feels like a water balloon or a water mattress, you're probably not going to succeed with compression on that one, or MLD. MLD will do nothing on the seroma. Compression might work on really small seromas, and that's why surgeons are apprehensive of aspirating. They would sometimes say it's going to go away, or even in Bridget's case, they said wait and see initially. And I think that the learning experience here is, if you have that on the chest wall, it's almost always better to have that aspiration, because the seroma can eventually contribute to the onset or to the development of lymphedema. There is quite a bit of research on there. Jody Vinegar, who is our breast cancer expert, she always does frequent updates, and I think we will see it more because of the type of surgeries and post-surgical care that is now coming into play. And so MLD and bandaging MLD won't do anything on the seroma. Bandaging or compression, maybe if it's small enough, but in Barbara's case, it was pretty clear what needs to be done. So, hey, I thank you all, the panel. We are far from being done. We have 6 more patients, and I promise you they're all great learning experiences, but I use that little buffer here. And Nicole, if you want to play a couple of videos about the confidence, which are super interesting, But if anyone needs to turn off their camera for a second and need to go to the bathroom, by all means, we're going to continue with our patient cases in about 10 minutes.
Yep. I am just going to mention, in case anybody isn't aware, the donning aid that she's using is the Ariane Magnide, and it's for closed toe, which is really nice. Those are magnets in the front.
Okay, I think we are back. So I'm back. I'm not sure where the others are. Yeah, we have
Back.
2 minutes. 2 minutes. Sophia, throw us another question that we have not gotten to. So we have 2 minutes before we dive into the next case.
A lot of questions around the name of the compression garment donor again, and what's the one for the closed toe. So we have several questions asking that.
Okay.
So I'll let Margie chime in.
Yeah, so those are the Ariane donning devices. And Jobst is the supplier for Ariane here in the US. And the one for closed toe is called the Magnide. And there's two of them. There's a Magnide and a Magnide 2-in-1, which also helps to take off the stocking. So we still do recommend rubber gloves to help with that when they're putting those on. But those are amazing devices.
Guenter, a question for you. How long is the recommendation for constant compression before you expect the seromas to stop refilling?
The best thing would be 48 hours. 48 hours and people cannot take it off for showering. Or now, of course, if there's pain, if there's something that is not feeling right, that needs to be addressed because you don't want to miss anything underneath that compression that needs attention. But the typical procedure would be at least minimum 24 to 48 hours. In that time span, you can expect those tissue layers to adhere, and it shouldn't come off in that time frame, not even for a shower.
Margie or Cindy, can you just touch on the confidence? Is it latex free? And there's a second part to that question. Will the confidence in an arm sleeve offer a wider silicone border that goes more than halfway around the circumference of the upper arm?
Yes, it's latex free. And you can either get the soft fit silicone band or you can get the 2.5 on top or 2.5. They call it half, but it's 3/4.
Yeah. Yeah, so you can get a full. There are options for both. I love the soft fit for upper extremity. I think it's one of the best options we have, particularly on a smaller arm.
And I think we hear that again in a testimonial later. We have a very interesting and fun video coming up in an hour from now. So I'll keep everyone in suspense, but Shanna will actually tell us a little bit about the experience between the silicone dotted band and the soft fit. Does that make sense to you guys?
Yeah.
Okay, cool. Hey, we're going to be moving on to case number 3. Of course, I have the pleasure of knowing all the case studies. I have talked to all of these people, but Cindy and Donald have worked on the next case. I'm super excited about all of our cases. But Nicole, would you be so kind and run the video of Frankie, which is absolutely fascinating case.
My name is Frankie Smith. I would say somewhere around 2012, I got sick, had a very high fever. I went to the emergency room and they did some tests and found out that I had cellulitis on my left leg. So with treatment and all of that, it kind of went away for a while there. But then it seemed to have came back and my legs started to swell, my ankles, my foot started there. Then they sent me to a wound care specialist, which I didn't understand because I didn't have no open wounds. So I was seeing him for about a couple weeks and all they were doing was just wrapping my leg. Thank God there was no open wounds or anything. So that went on for about a good 6 months. They also ordered me a pump for my leg. I started doing kind of okay, but then again, here it comes again. It just kept coming back and forth, back and forth. So then they said I needed to see a physical therapist who dealt with lymphedema. So I was going to Lincoln Hall Hospital at the time. So I went to one of their physical therapists that was outside of the hospital. I got with her for a few months. She did wraps, but not the way that Donald is doing them now. She was wrapping me with ACE bandages, which was not well, because by the time I got back in the car, they would start to fall and this and that. Then slowly but surely, a mass has started coming on the inside of my thigh. And so that went on for about a year. And it kept getting bigger and bigger. So I was seeing my doctor, and I had asked him, is it possible that the mass could be removed? The mass kept getting larger and larger and larger, and it was becoming a hindrance to my everyday life. So they sent me to a surgeon, which I don't think he knew anything about lymphedema. So he said he would go ahead on and remove the mass. They did tests and everything, and that was done September of 2015. The mass was removed. It was about a 30-pound mass. They removed it. I was doing well for about 9 months to a year. Then it came back full force, like it just wanted to go to war. It started coming back in the feet, my calf, and then double time in the upper thigh area. And that's what I've been fighting with ever since, until I ran into Donald at Penn.
So this past October we met for the first time, because he had been dealing with this. He had been using a walker. He has very minimal resources to get things. So I think he had only seen one other lymphedema therapist before me, and they had just told him to kind of save his money, to kind of give either Advantage Alternatives or something, just because he didn't have any resources or anything to kind of get formal treatment. So when he saw me, seeing that he really would benefit from a full course of CDT, and I mean traditional CDT, I talked with him, because my first evaluation was to really explain to him what was going on with what is happening with his body, because no one had ever explained to him what he had, what the why certain things weren't working, why water pills weren't working, why ACE bandages weren't working. So no one really explained to him what lymphedema was, why these things were happening. And so after explaining that and how we treat it formally, we had come to a understanding. So I was able to donate bandages and supplies for him. And then as far as resources, I had contacted everybody like possible. I contacted Cindy, I contacted someone from Joey Pack, I contacted everybody. So basically, I was able to get enough resources to be able to get a formal treatment for him and to get him started. And so that's kind of where we were.
And ever since then, this young man has been a godsend from heaven. And I mean that from the bottom of my heart. I was about to give up on everything, because I had just got tired. I had got tired of nobody wanting to do anything, nobody wanting to help me. You're sending me here and there, but no one is even trying to help. Mm-hmm. And it has been a pleasure. It has been a joy. I have stuck with it. He has stuck with me. And I'm just grateful from the bottom of my heart for him. And I'm grateful, and I'm happy to see just where he's truly going to take me. I know he's going to take me to the end, but I just can't wait to really see what the end is going to look like and to be normal again.
As far as clinically, when I measured him and did his circumferential measurements, it was a 156% volume difference. So I took I measured both his legs. His other leg was also edematous as well, but it presented more like a phlebo lymphedema. And so, but again, you can also see fibrotic lobules in his upper thigh on the right. And it was a significant amount of fibrosis on the right calf as well. So, and his initial weight was 427 pounds. He had expressed that he had never seen less than 400 pounds in a very, very long time, I'll say.
From your point of view, I already spoke to Donald and he told me what he was doing, but I want to hear from you.
Is he here?
How the treatment started and how it was different from earlier episodes of care.
The first thing, Donald sat down and talked with me, not at me, he talked with me. He wanted to know what was going on with me. Then he also taught me about lymphedema, what it was all about, where it's at, what's going on, how it flows and your lymph nodes and all that stuff. That wasn't revealed to me. And a lot of things that he was saying, it finally started clicking.
We started off seeing him 4 days a week, and I wanted to get 5, but I had to compromise. He goes every Friday to get platelets. So we meet 3 to 4 days out of the week. As he's coming down, we kind of back off a little bit just to give him a little bit of a break, because he, like I said, he is so he is so committed to it, and he is just very just enthralled with what we were able to do for him. So
yes, I'm walking a lot more. I'm cleaning out garages. I'm doing things around the house. I'm going up and down the steps a lot better. I can even go to the market. And it's just a good feeling to start to feel normal again. I'm able to stand longer to do things where before I had to sit because of the lump. And then sitting was even hard to do as well because the lump was right there and it would prevent me from sitting properly in a chair because I couldn't sit back. I would always have to sit on the edge of the chair. But now I'm even able to fit in a regular sized chair with arms.
Yeah, these are the little things that many people don't appreciate, right?
Exactly, because in Donald's office, he has a large wide chair and a regular one. And one day we were sitting there and I happened to turn and look. I said, oh my God, look where I'm sitting. I'm sitting in regular size. And I was able, and my legs did not hurt. My legs were able to close being in that chair. Before, it was always hard to sit in a regular chair because that lump would always prevent me, and it would hurt so bad where I would have to sit in something larger or just something that didn't have arms.
Mm-hmm. Right. No, this is a fantastic, I want to say turnaround. And and you're just, fortunate to have such good support system.
Yeah. Oh, his weight now is it's between 384 and 378. So he was very surprised when we had weighed him, because he was just very surprised at how much of that had come from what he was carrying with him on a regular basis. Yes.
I'm able to not only tie my shoe, but I have a shoe that Donald gave me that has Velcro. I was shocked. I honestly stood up and bent over and was able to hook it myself. And before, I was about to fall my big behind over, but I did not tip over this time, Donald. Thank you. And didn't get dizzy either. Did not get dizzy. So I'm come a long way.
Beautiful life that you're living. That's great.
The man deserves a Nobel Peace Prize, and I'm going to do everything in my power to get him some kind of award from somebody I'm working on it because he deserves it. I was at my end. When I tell you I was at my end, I was at my end. I don't want anyone to ever go through what I went through for 5 or 7 years that I can't even remember. I don't want to remember, but I just don't want anyone to ever go through what I went through. And if they can find someone like Donald to pull them out of it and pull them through, oh my God, your life will change.
So I hope you enjoyed the story. It was a fun interview. We did it in 2 steps, of course, but it's an amazing turnaround for Donald. And I think recapping what we have seen here in the video, I think we need to recognize that the 2 main ingredients were there, and that is patient motivation, even though the patient sometimes does need a cheerleader and we need to kind of like tickle the motivation out of the patients. But, you know, having had Donald talk with Frankie and not at him at the initial consultation already made him feel at ease. And I want to also acknowledge Thea, who is part of the therapist team. You saw her sitting behind Donald there on the side. It's usually more than one person who actually can, you know, tackle a limb like this. I hope, Donald, you're going to turn your camera on too. I know you're there. I know you're there. So hoping that we will see you as well. So, Sophia, I mean, first of all, congratulations, Donald. I know Frankie is not quite at the very, very finish line, but at the point where he could be fitted for garments. And Sophia, do you have any questions for Donald or I or Margie or Cindy?
We just have one at the moment. Regarding surgery. So is surgery more of a last resort in most cases? And it sounded like it wasn't really appropriate for this patient at this time.
It's oftentimes, not necessarily, I wouldn't see it as a last resort, because I think people who in that predicament, like we see a patient coming up right after Frankie, we see a patient who is probably going to have surgery soon. I don't think it is necessarily the last resort, but many patients are not candidates for surgery because of their general condition. So, for example, Frankie needs platelets. He has issues with his platelets that need to be replaced or added every week. And you know, these people are not good candidates for a surgical procedure, because even though it would be good for the lymphedema, it could be really adversely affecting some other conditions, or they may not heal very well. So it is oftentimes that they are lucky to find a therapist as dedicated as Donald and Thea to actually tackle this kind of like leg. Donald, of course, we have done the interviews. Is there anything important that you feel like we left out of this case?
No, I think that really covered a great deal of just what Frankie went through, and myself. I know, like I said, the only thing I know that, at least from what I have experienced, is that a lot of times patients will come in and they will have difficulties or hardships, whether it be getting there, transportation, whether it be, sometimes it's more than just the bandaging and the doing the formal treatment. It's sometimes other components that, you know, if those things were at least removed. So I know that, you know, Tia and I have worked really hard to try to be advocates for our patients, not just from a therapist perspective, but sometimes we have to, you know, be their social worker, or sometimes we have to find transportation, or sometimes we have to find, you know, if there's a astronomical copays, because, you know, to come and see us may cost some monies. And so, getting things waived. And so there was a lot of moving parts to, to get him, to our first session. And so, I gave myself a month to get all those things in line, so that then, because I had to have at least 3 different plans to go to, so that he would be successful with it. So, success is not just being a, therapist, but also other.
It almost like sounds a little bit too easy when you watch the video, because there was a lot of love and praise, but there's also a lot of hardship and a lot of work that leads up to it. Sophia, do we have any other questions before we go into the measuring, which was also done awesomely?
Yeah, so any tips or tricks to help keep the bandages up all the way?
Oh, yes.
Go ahead.
So I used a combination of gray foam and the Comprex 2 foam with the ridges, but to keep, so what I ended up having to do, because of where the lobule was, one big thing for him was, 1, I had to keep it up, and 2, he had to be able to bend his knee, because he couldn't bend if I bandaged it going, if I wasn't paying attention to my bandaging, then the lobule would kind of swing around to the back of the knee, especially the looser it got. And so then that would prevent him from a lot of being mobile. So I had to kind of I had to kind of readjust as I was bandaging. So I would have him either do it in lying, or lying, and then I'll have him sit, and then I'll kind of readjust it. So my, I think one thing we had used was we used 1 layer of ACE bandaging on him, and that was to help to keep some of that up especially for the weekend. And then we also used something called edema wear, which was really helpful to help with the fibrosis as well. And it helped to kind of to keep that keep the bandages up too. So it helped on 2 fronts. I hope that answered the question.
Awesome job. Awesome job. And I promise, Donald, we're going to make a real case study out of Frankie and hopefully help other therapists tackling cases like that. So I want to shift into the measuring. Is there any measuring question before I shift it over to Cindy and Margie?
Everyone is really interested into seeing what garments and class of compression that we used on Frankie.
Okay, so I'm going to hand it over to Cindy and Margie to share their screen.
Yep.
We did not use any pads.
No.
At least not any breast pads.
So these are Frankie's. This first picture was one of the first ones that Donald and Cindy sent over. And the progress that you've made with this patient, Donald, is just amazing. I know he was praising you, but as I saw these pictures, I understand why you're getting so much love, because it really is, you've made amazing progress with this patient. So Cindy, I think this is probably when you may have measured him, because we still have another picture after this.
Yes.
That the patient actually reduced even a little bit more.
Yep. So should I go over what we measured him for?
Yeah, because I was able to plug in as many of those photos that you sent over. So last minute, but I got them in there, I think.
Yes, yes.
That's a lot.
It's a lot. Okay. So we did bilateral toe caps. The toe caps on his left foot was in a class 2, and then class 1 for the right foot. He had bilateral knee high that were both in 3/4. We did a 5 centimeter silicone band, and we slanted the top for the anatomical fit. We then did a B to G, so the ankle to the groin, we did in a class 4. And that's really high, but this guy has a lot of fortitude. So we did that in a class 4. And then we did leggings, Guenter, is that what we're going to call them? Because they're not fashion capri.
I hope you will.
We did footless pantyhose, and that was done in 3 Forte.
Did
All of
you
it.
do a different compression in the panty part? for
No,
him? No.
no,
Okay. Nice.
I don't do that. I've had, I know I'm a little different. But I keep the compression in the panty the same as the most affected leg if there's a lot of edema in the torso, or if there's any fluff in the torso. I like, because Laplace states that it can handle that kind of compression. So I haven't had any issues with that.
Okay. I do want to chime in and caution people to do this kind of like approach on everybody, because you really have to, and speaks to the individuality of lymphedema. Lymphedema is kind of like so unique from one person to the next. Now, Cindy, you're absolutely right. According to law of Laplace, we could go past a 4, and because of his overall circumference, it would be the same compression as we would put like a 2 on your body, okay? Because it is inversely proportional. The pressure is inversely proportional to the radius. The one thing that I really have to kick back to Frankie is, like, based on his experience, he has that strength and willpower to deal with that. I am quite convinced that for Frankie, it's the right thing. But I have to tell everyone who is here on the call that we will have another patient coming up for whom this approach would not work. So it's really an individual decision. But Cindy, you have it going for you because Frankie is so determined. Go ahead.
Absolutely. I'm going to move to a few more slides. So this was the most recent one that I got from you today.
I need to chime in here one more time. I want everyone to look how close his legs are. He would not have been able, and this causes so much orthopedic issues. If you went back, just Margie, for just a second, to 2 slides ago, when you show his first picture, or the first one. Yep, this one. This one was, no, the other one, this one.
Sorry, this one.
So on this one, you see how naturally he would now be splaying his legs out like this. There is a distance from probably 60 centimeters between his feet. That cannot be good for anyone, for the knees, for the hips, for his entire posture. Donald, if we now stopped here and said, okay, we're done, Frankie would already have won in a big way, because his alignment is so much better. If you now go to the next one, and the next one after that. Now look at this. This is absolutely amazing. So sorry, I needed to point that out, because that in itself is a major success story. So go ahead, Cindy.
I guess we'll go to the next slide.
Yep. So this is just I don't know if you want to walk through a couple of the measuring. Now, you measured him while he was actually laying on the table, correct?
I measure everything up to F. Supine.
Mm-hmm.
Yes. And then I took G and all the body portions standing. So I was measuring the circumference of F, and that is a very snug circumference that prevents the sliding.
Yeah. And just some considerations there at the Y.
Yes,
like, you might be doing the B there, but.
At the Y, I had him over exaggerate the dorsiflexion. And then I measured high on that anterior tendon to ensure that I was going to open that area wide enough.
Yeah. And you could see, it looks like he just got his bandages off. So I think that's great when you can see. And I think you referred to that. I think there was a question earlier, Guenter, about spaghetti foam. I think it's that channeled foam, right? That can really help with those areas.
On the bottom, it looks like spaghetti foam to me, which would be technically the Comprex 2. And then on the leg, he has the edema wear, which I just want to explain for people. Edema wear is not going to control Frankie's edema. That is more like edema wear comes in when you have like maybe like a small orthopedic swelling. But edema wear can be used as a liner, if you will, on the skin. And I see Donald is nodding. That's a good sign. Because it actually is a little bit like has the properties of tubic grip, but the strands for the support go longitudinally. So it actually lends a little bit of traction, so the fluid, the bandage does not fall down as easily. But edema wear would not control this kind of like edema. It's just kind of like a stockinette that you put on prior to your wrapping. So go ahead, Cindy, take us away with the measuring.
Yeah.
Okay. So you see I have my flexi card there to get the digit lengths. I measured at the very tip of the toe cap. I see a lot of toe caps that come short. They end at the nail bed. And we do that for upper extremity because we need our fingers to pick things up with. If we end that toe cap short, or that the length of the toe short, you're going to create a bulbous toe. So you want to make sure you take that toe cap all the way to the end of the toe. And I'm very generous with my circumferences of my toes. Oh, and here we go. This is what we're putting into. They fit.
Yep. So here are the leggings, I'm guessing, right?
Yes. So we have, that's everything put together. That's the entire thing put together. The knee highs, capris, everything. Leggings, sorry.
And I do have some pictures of separate, so.
Okay.
Yeah, and I mean, in Margie's and Cindy's defense, these pictures came in like a minute before we gone live this afternoon. The garment
last
was
ones I did during the video.
Yeah.
That garment was literally delivered today. I want to use that as a learning experience too. I mean, first of all, Frankie is not yet kind of like adjusted in the garment the way he will be when the garment has been worn and washed a few times. This is so important. This is a simplest thing that you can do to assure a good fit is to wear it, wash it, wear it, and wash it. And don't be too judgmental like on the first try putting it on, because you need to break the garments in. But I just want to tell everyone that this was literally last minute add on these pictures because he just got them.
It was held up due to snow in our area. But also one of the things that's very important is I will oftentimes hear patients or talk to fitters and therapists that put the garment on and take it off because something just wasn't 100%. We know nothing else about the efficacy of that product. You put it on, you take it off because I don't know, is a little bit too long or a little bit too short. Wash and wear it for a week to assure that the garment's working. If you put it on and take it off, we have no idea what that garment is going to do for the patient. So I've also heard patients say that they were concerned that washing it could actually void the warranty. It's a prerequisite with us. We want the garment washed at least 5 times, worn and washed 5 times, unless it's causing injury, of course. But we don't know anything about it if it's put on and then taken right off. So washing it is extremely important.
So I have a couple more slides where Donald took separate so you can see the toe caps. And this illustrates what you were talking about, Cindy, that the toe caps actually cover the whole toe.
Yes, but I would like to see that toe cap come back a little bit further.
Yeah.
On that foot, Donald. All the way back to.
And
I know you were probably trying to get pictures, Donald. So we're not going to hold you to
a really quick photo op. That's true.
Yes.
Yeah, but it could have been my measuring too. So let's not. I'm not pointing the finger.
No, I think let me chime in here. I think you need to, and I know Donald knows all this, but With some rubber gloves and a particular technique, you can push that a little bit back. I don't think they are too long. And what Cindy was saying, like really bring it up over the nail when we stay at the nail bed, that's an upper extremity thing. It's not a lower extremity thing. It's not a toe thing. So I think they will eventually, they don't look too long to me. It looks like there is a little bit of a dawning, tweak that we need to do, but I understand you are in a rush. You were in a rush putting this on and taking the pictures for us. So I'm grateful for that. Cindy, do you think that the length of that toe piece towards the dorsum could be a little bit extended next time?
Yes, I said that. Yeah, definitely. I would like to see that much longer on the dorsum of the foot. Yes.
Okay, but again, this is not, it's not like he couldn't wear that now until, another time when you do the next round of garments.
Yeah.
Okay, sorry for chiming in here.
Yeah, I really love these knee highs, Cindy. And I know you mentioned you did the higher on the outside, and I love that, particularly when there is a lobe.
Yes, it's more anatomical, and we really want to incorporate the calf in that. If we done a straight top, there'd be a lot of lateral tissue that would not be addressed, at least in the knee high.
Right. And it gives him the option. I always like to point out that we know, we want people to wear their garments as much as possible, but I love the knee high combo, that if somebody does decide for one day that they don't want to put on their whole garment, that they have the knee highs as the fallback.
Donald's not going to be that nice.
I know, no, Donald, don't give in, but we know sometimes.
Margie?
Yes?
2-minute warning.
Okay, great. So I think I have one more picture where I put, this has the B to G.
And then measuring the slope on the left side, Cindy, any pointers for measuring that lobe?
I lifted that lobule up a bit so that when I took my F measurement, my E measurement first, because I wanted to make sure that I could incorporate just a little bit of that in that circumference at E, but I moved that lobule up just a little bit so that it was in the proper place for when the garment was pulled on, which is why I measure all my patients supine. I want to have that lobule lifted a bit because I really am not good with saran wrap. I can't wrap a bowl, so I can't use it.
And then the transition, what strikes me here as a little bit of a tricky area is that transition between your E measurement and the F measurement. Now, how did you do anything special to accommodate for that?
All I did was I gave a really good firm pull to the circumference of F. If he had been fluffier, had more adipose tissue in that area, it would have been even easier to pull, but it was still pretty firm at that point. So I just gave it a good pull.
Okay, and then the other thing, to make a stocking like this work, you really have to tuck the tissues in when you pull it on. I think, Donald, you put it on him this afternoon. Tell us a little bit about this tucking. We still have a minute here.
So, when we were donning the B to G, we used a combination of the gloves. So we used the gloves, and then we also so Frankie did a really great job of managing the B to G garment, and then I kind of helped to shift it the lobule in place so that it can stay where it needed to, because I wanted to make sure, again, it didn't kind of swing to the back, but it really held very well when he put it on. Even looking at the thing as a whole, like I said, so it yeah, I mean, it took some maneuvering, but it really felt really well with the way that the B to G and the Capri kind of went on.
Donald, can I ask you, what was his response? What did Frankie think?
He was very excited. He actually wanted to wear it home. Unfortunately, the Jovi pack that we measured him for didn't come yet. So, so we had to rebandage. But yeah, he really loved it. It held him well. He was able to sit in the chair. I think in a couple other sides, the chair is in the background of the chairs that he either sits in. But he was able to sit in the small chair and bring his legs together, which I tried to really show. So the garment really did a very good job of not only containing, but really working with the pliability of his skin texture, especially once we reduced a good bit of the fibrosis. So when I took it off, I was really excited just of how the skin just kind of fell very loosely. So it really did a fantastic job.
Oh.
But see the commitment of the therapist, not letting him go home until he has the appropriate night compression. And I really, in my heart, Donald, I think that lobe can reduce much further. If everything goes well, there's no reason why he would not have that reduced anymore. But awesome job, you guys. Any urgent last minute message? Margie, is there something you want to say?
No, just unbelievable job. I mean, I'm super excited to keep following him.
Yes,
yeah.
We will follow him for sure. And Donald, you're not off the hook taking pictures for us. So thank you.
No
problem.
Yeah.
Yeah. All right. Hey, cool. Very, very good job. We're going to move on. There is a similar but very different case that we want to present. A case which is, again, similar in nature when it comes to the development of the edema. You will hear from Chris in a moment. If Margie, you would allow Nicole to cue up the video. And this is Chris's story, the only person I've not personally talked to, but we're gonna hear later on from Emily and Rita about this person. So Chris did a selfie for us. Go ahead.
Hello, my name is Tibor Kovacs. I usually go by Chris. I'm recording this video basically to tell my story and go over my situation with my leg. So right now I'm 38. I'll be 39 next month. And so when I turned 30, that's when pretty much everything started happening. So when I turned 30, I noticed just working at the job at the time, I noticed my right leg started swelling, and then basically battled with finding a doctor that would be able to diagnose me, which they pretty much said nothing about lymphedema. It was just, basically telling me I needed to lose weight. I was borderline diabetic, one said, but never really did any test. So it basically just, I got discouraged, gave up for a few years, and then it got worse. And then, so eventually I found a good doctor that my insurance covered, and she was the first to diagnose me in 2015 with lymphedema, and confirmed it through another doctor. And also that's when we started doing wound care and everything else. Unfortunately, I lost my job a year later, or a year and a half later, because it started getting bad. I had like a bad issue with cellulitis, and anyways, lost my job, lost my insurance in 2016, and then it took, I went untreated again, so again, my leg got kind of worse, and then it was not until 2018 when I finally got a good job again, got insurance, and then through fate or whatever you want to call it, ended up meeting Dr. Sokas. And Dr. Sokas, immediately knew what to do. We did some pressure treatment the best we could, but really it was just wound care. He did the Charles procedure, and eventually in 2019, it was in May, I was in the hospital for 2 months. Had a few setbacks, mainly because I didn't know that I was borderline anemic. So basically, besides that, I had an infection that popped up, but other than that, everything went smooth. My leg got better. It looked normal after the procedure, but I had some sagging, loose skin up in my upper thigh, close to my groin. And so then skip ahead to the end of 2019, going into 2020, I stopped seeing my lymphedema specialist at the time because, I got sick at the beginning of the year and ended up canceling a few appointments, and then COVID happened right after that. So there was a good couple of months between like January and like April of 2020 where basically that loose area of the upper thigh just backfilled and got huge again. So, and my foot was always kind of an issue too. So my foot and my upper thigh both became a problem again, to where they had to look into possible surgery, but we still wanted to do pressure treatment. So, and we still had the lower leg, which had a Charles procedure done on it, and it was fine. We just needed proper garments, and that's where you guys came in and provided me an Una boot, which did really well, but we needed something that could go much higher up to the knee, and that's what we got currently. And so far, it's been working really well. We notice a big difference that it helps with my foot, because without it, so for the past 2 days, I had to wash it. And also we took a break because I had some issues with the side of my foot. So while I wasn't wearing it, I noticed a significant difference between when I was wearing it and wasn't. So it definitely is helping. But that's pretty much my story. So yeah, it's just been one thing after another. But and hopefully really close here soon, I'll be having another Charles procedure done on my upper thigh. And potentially my foot, that's kind of up in the air. But the product you guys provided me will help at least with my lower leg, no matter what happens. And I'm just looking forward to, being able to have a healthy leg so I can get my mobility back. So, because I haven't wore a pair of pants in, let's see, gosh, since 2013, so, not almost eight years or something. It's been since I've actually wore a pair of pants. So, and actually even a regular shoe for that matter on that foot. So anyway, I'm looking forward to continuing to work with you guys.
All right, guys. So this is the Ena boot that we measured for Chris for the lower leg. We just put it on. We have a liner on underneath to hold an ABD pad because we're having some lymphorrhea on the dorsal ankle crease area. But other than that, it's a 2-person job to get on the Ena boot. We're looking into Dyson for ease of getting it on, but Chris, you think it's comfortable?
Yes, absolutely.
So we worked together to put all the straps on as well. And it doesn't seem like we had any shearing. The first time we took it off, we had a little issue with just moisture and some maceration between the wet spaces of the toes. But other than that, we have been wearing it successfully. And Chris, you feel like your leg is down when you have it on, right?
Yeah, absolutely.
And we take it off and we noticed a lot more improvement in the fibrosis breakdown as well.
So definitely a very, very different situation, even though initially you may think, oh, wow, that was very similar, but it tells you that everyone is quite unique. So I want to give it over to Margie and Rita, and of course, Emily too, that Ena boot, Chris called it an Una boot, but it's not an Una boot, it's an Ena boot. So tell us a little bit about that, and Sophia can scan for questions that we may have later on. Rita, you want to go first?
Sure. Well, this has been a work in progress. I mean, in between Emily and I have to say a lot of our wound dressings were involved in this case as well. But we've been working with Chris now for a couple years, and this ENA boot was a really big success for us, and being able to get something on Chris that has really maintained him. So I'm going to let Emily kind of take it from here and just talk about our journey. And then if I can I share my screen to just show Chris's pictures?
I'm sure you can. Nicole will make it work for you, but Emily, fill us in from your side of the story.
So when I started treating Chris, he had been out of time because COVID actually shut down our clinic. So we were not taking any patients, but when we did pick back up, I saw him July 2020. He had significant wounds there on that upper lobe. And those pictures I posted are kind of after some debridement that we had to do. And we used a lot of the Cutimed, Sorbion, and Sorbact products to really help with the wound care and to remove a lot of that bioburden. And he had so much lymphuria. Like, he was just, I mean, it was constant. And so we had to keep wrapping. And our short stretch bandages, we were constantly going through them. But what we noticed was that he has a trilobular region left over from surgery from the first Charles procedure. And so he does tend to get a lot of lymphuria from there because everything is bottlenecking. But he had severe hyperkeratinosis on the lower leg and foot, took a lot of soaking, and we used a lot. We used the Cutimed, we used the foam to help with that, the acute foam, and that really helped soften up some of that harder hyperkeratinosis. And the foot continues to be an issue with the lymphuria as well, and trying to pad it. We've used spaghetti foam, and we've used Comprex as well, but he does rebound very quickly. And you'll see in the back as well, you can see that trilobular region. It's everything gets smushed there, and everything goes up into his gluteal region. So it's very difficult for him to sit and to mobilize. We had to get him a special chair and a lot of other assistive equipment, but he is looking to have the second Charles procedure to complete. Well, we don't know yet if anything will be done at the foot, but definitely at the upper lobe, because he'll use a compression pump as well. And we utilize for MLD all of our available pathways. And he recently just had some superficial thrombophlebitis on his anterior thigh that he was trying to get managed with some antibiotics. We've kind of had issues on and off with infection control for him as well, because it's increasingly difficult for him, and he does not have this family support of somebody there. So he comes to see me 3 times to 4 times a week, but has to also get transportation as well. So it's definitely a complex case, especially with that Charles procedure and trying to maintain the health of that skin and the lower leg too.
Yes. Okay. Thank you, Emily. So the reason why with Chris is that we chose the ENA boot, and I do have the ENA boot here with me today, is because after we did do quite a bit of our wound care in here, and we had our wound care representatives involved as well. So we initially, as Emily was saying, we used a lot of Siltec Sorbac and the Sorbac swabs because of the heavily draining wounds that Chris did present with. Well, when it was time for, a garment, we really needed something that would be extremely soft and fragile on the skin. And that's why we did go with the ENA boot. So the ENA boot, I hope if you can all kind of see it here, but this garment is really nice because it's made with a nice organic cotton on the inside. And over the top of it, it has an adjustable liner that you can pull adjust to get the compression just where you need it. But it's also easy to slip on and off. And, it was ideal for Chris's situation. As Emily said, like a lot of this skin shearing and everything we've been coming up against So this was really the garment. It works for the vascular insufficiencies that Chris is experiencing, as well as lymphedema component. I will say in the 2 years of this journey, his foot is amazing now, right, Emily? I mean, from then until now, just the fact that his foot has even come down has been really nice to see that. And here, so you can see the foot there. Oh, thanks, Margie. Whoever put that up, that makes it helpful. And this was the Charles procedure that he had done here. Okay, so you can kind of just see here why we went with that decision. Okay. So, and okay, so, and these are these, if you want to just go back there, yeah, I can talk about that for a second. The sore back. So with the drainage we had, we did do some of the Siltec sore back. We used a lot of swabs. We did some Sorbion in there as well. And this is the—
What is this? Yeah, and quick question to both of you, Rita or Emily, maybe more. What is his general condition? I mean, is he otherwise pretty healthy? I mean, we don't need to, you know, we don't need to speculate. He's obese. He's very obese. That probably led to this picture that we see now. But is he otherwise maintaining pretty good health?
So if you, I mean, you can't really see the other leg, but I think if you really take a look in the video as well, when I started speaking with him, I think there is definitely a primary etiology somehow involved in this, because his eyes, the position of his eyes, and the fact that he was born a month late, there could perhaps be some sort of genetic chromosomal condition to this as well. He does have some significant eye issues. He does have hypothyroidism. So he does have some other things going on that are not as commonly seen. But yes, he has obesity as well. And a lot of that, I think his mobility is severely limited. And so he's not moving obviously as much, and his diet, you know, he lives in a 2-story home and he's not preparing any food for himself. So he's really going a lot off like frozen foods, and we've really tried to get him. He's done more of meal planning now. So he's lost about 45 pounds in prep for surgery as well. So he's definitely in better shape, but I think there's probably some other underlying genetic things going on that just, you know, maybe haven't been looked into more.
Yeah, and I think from just a therapy point of view, and I know a lot of therapists who are now on the call, they would say we are not able to diagnose, and I don't want you to diagnose, but I think for documentation purposes, I think this would be better documented as a multifactorial edema or lymphedema as opposed to primary. I mean, the genetic component, as you said, is a strong possibility, and it's likely there. And yet we have, and I wouldn't strictly document it as an obesity-induced lymphedema, which would also be a better documentation than saying primary lymphedema, but multifactorial or multi-causal edema / lymphedema would certainly meet that description. And I think at this point, we really have to acknowledge that throwing a garment on his thigh is probably not going to help him a great deal unless Chris could actually be an inpatient somewhere. This is not the type of lymphedema treatment that he can easily accomplish like you do in outpatient rehab, but you're definitely doing an awesome job keeping his foot under control. I think the Ina boot, which is also relatively new to me, would indeed be an option for some of the patients who are in a similar condition. Any questions? Did we get any questions, Sophia, in this particular case?
Yeah, so a lot of questions regarding what the Charles procedure is. Can you just shed a little light on that?
Do you want to do it, Emily, or should I give it a shot?
You are more than welcome to if you want, but I can also, I'll let you do it. And then if I have anything to fill in, I guess I can fill in any of the stuff.
So a Charles procedure is probably the most, I want to say, quote unquote, aggressive procedure that anyone with edema or lymphedema can have, in that they actually harvest some of the skin literally with like a little chafing device. They harvest some of the skin, but then they excise everything that's left on the leg down to the muscle fascia, because that edema that you see, amazingly, is not below the muscle fascia, it's outside the muscle fascia. So everything down to the muscle fascia gets excised. And that's where the lymphedema usually develops, between the muscle fascia and the epidermis in that department. So if you cut everything out and then use the skin that you harvest for skin grafting afterwards, and that's where his skin on the calf will never be perfect. In many cases, it turns into a really thick, indurated scar. And in Chris's case, I think it's so delicate, where even with compression, you need to be careful, because typically when these scars heal, you can compress like crazy, but you don't even have to compress like crazy, because once the skin turns into a big, thick, heavy, indurated scar, that's your compression right there. In Chris's case, it's more like a skin graft that is kind of like not super well healing. That's my impression. Now, Emily, chime in if I said anything wrong.
No, I think I mean, that's absolutely, it's like spot on. I think, when I hear Chris's video, and we talk about the rest of the procedure, that's a huge undertaking to do the thigh as well. And he did have a skin graft from his abdominal region that was used along the lower leg. And it was a very, large procedure for him to undergo. He was in the hospital for a little over a month, and had some issues with healing and infection and things like that. And the skin grafts are so painful, but then it's really that self-care of managing it. So I think it's really valid to note too that I've been trying to kind of prep him, and I think there's a huge psychology component that I almost feel like has to be factored in this case, because, there's a lot of talk of, when my leg is healthy or when my leg looks a certain way, but with this procedure, it's such a disfiguring procedure for someone, that I think a lot, he's just kind of ready to get it off and to get moving. But there's just so much more involved. And then with the foot as well, the fact that we could have like some gangrene for the foot could be an issue as well.
Yeah, so there are this is an extremely complex case. It's an extremely complex case, but Sophia, we have time for one more question if you have that.
Absolutely. These are going to be for Rita. So Rita, what is the compression of the ENA boot? Is it a custom or ready to wear? And what liner is being used? I know it's a multi-fact question for you.
Sure. So I'm not Margie on the compression. Do we have a listed compression on it? Oh, you're muted. But I will take it. So it is with it's the organic soft cotton that lines the ENA boot. Emily mentioned they did have a liner there because of Chris's drainage and going with that drainage, but really in all this time we've been working with Chris, this is the best garment that was ideal for his situation, because this garment has that vascular component as well. So it's a spandex that goes over the top layer here. And you can see here on the garment. So when you have this layer over the top and you pull it, you're getting the compression coming over this top layer here. And another reason why we did choose this garment for Chris is because it's ideal for day and night. So you can use this garment all day, adjust it when you go to bed at night. And this was really important as well. I have to mention the bottom of the foot here. We call this a tough text. And basically this is a non-slip pad. So this was really important that, we kept in mind that we did not want Chris to fall or to slip. But I'm not positive actually on how much compression. So maybe if Margie can take that.
Yeah, and because it is adjustable, I want to say, normally we would probably call this around 30 to 35 during the day. Again, like Rita said, you could leave it on at night to adjust it to a much lighter compression. And that's kind of the beauty of the Velcro. But this is actually considered a daytime garment as well. And I think it was a really good choice because you guys had such a problem with his skin.
Oh, you can't put any, oh, not to, interrupt.
And I
but
think
his skin is so fragile. I mean, Emily and I talk about this all the time. Like, our dream is for Chris to wear an Elbrex garment, but we kind of know the reality of what needs to happen before that happens. And this having that soft organic cotton layer was really, I mean, we don't really have a lot of options when we look at garments in this situation.
Right. No, I think it was a perfect choice, and it will be a long time. If you do a traditional compression garment, you have to consider the shearing forces.
Yep.
And there is no way, unless you have an absolute reliable liner, that you could get a garment on that would not, the shearing forces would offset what you're trying to accomplish with the garment. So I think the Ina boot, we have to be really specific that it's an Ina boot and not an Una boot, is a very, very good choice. So I appreciate you, Emily, coming on this call to fill in, and Rita, good job. We'll hear from Chris again, hopefully in a very good, positive way the next time, I hope. So would you, Nicole, line up the next video for us? And the next video is all these cases, I think, are fascinating and interesting. We have another very interesting case coming up, very different. And I would like to introduce you to Rhonda.
On my last trip from where I was into Winnipeg, it was about a 3.5-4 hour drive. My legs started going numb. It's gone numb before, and I don't really pay much attention to it. Just rearrange my leg and keep on going because I don't have time to stop, because we're often under time constraints, and I was particularly on this trip. My legs started to swell while I was on my deployment. So before this last trip into Winnipeg, on the last day, it had started to swell already, and it usually swells right in the top of my foot, is where it starts. And then in the past, it's gone away on its own after a couple of days. So I had about 4 other deployments where this happened. I had seen the doctor and a couple of other people just to say, I don't know why this is going on. They recommended that I just get compression stockings and pay attention to what was going on and try and look after myself better when I was on the road. So I started wearing knee-high compression stockings that were measured properly for me. So I was wearing those when I was getting deployed in order to avoid and to help whatever was going on with my foot. So the last time I was wearing my knee-high compression stockings, the foot started to swell. I was like, well, I'm sure it'll go away like it normally does. This last time it didn't go away. So it started filling in my foot, and then it started moving up my leg to my knee. My compression stockings were starting to hurt because I think it was cutting the circulation off at my knee. I ended up going to the emergency room as soon as I got back from Winnipeg. I live in Brandon, so that's about a 2-hour drive. It's about 200 kilometers between Winnipeg and Brandon. So when I was able to get home, I went to the hospital and said, my leg is obviously bigger than the other one. So they checked me for a DVT, nothing. They suggested I just keep wearing my compression stockings, and that was about the end of it at the emergency room. So I was like, okay. It started to hurt, so I was like, okay, well, I need to go back to the doctor. I went back to the doctor, and because we're in COVID, my appointments are over the phone. So she's like, well, I don't really know what's going on for you. We can send you for more tests. So she ordered a CT scan and an ultrasound. I was also seeing an acupuncturist at the time. So she was able to see me in person. She also had no idea what was going on with my leg. She tried some acupuncture to see if that would help reduce the swelling, it wouldn't. So I met with her and we started some massage, and also she wrapped the bottom of my foot. So just from the knee down. So we did some wrapping and some massage, and my leg got worse. So the swelling then moved past the knee into my thigh and into my genitals. Still nobody kind of knows. And then my foot went really red. So I called my general practitioner again. I said, well, now my foot's red. And she's like, well, maybe you have cellulitis. And I said, well, I don't know. So I sent her some pictures. We did a round of antibiotics. It didn't change anything. My foot is still red, especially when I stand on it. Then what did we do? Oh, she sent me for the lymphoscintigraphy test. So I did that. It came back normal, except for there's some slow movement on my left side, but it's my right side that's swollen. My CT scan came back normal. My ultrasounds have all come back normal. And as my legs started getting worse and nobody could tell me what to do, that's when I got a hold of Linda. The top part of my leg is back down to normal, I'd say, from what I remember. I don't remember. And then the bottom half is still, it has some swelling still. And then my foot still goes bright red when I'm standing on it. And you can visibly watch the fluid go back into the top of my foot. And I get lightheaded when I'm standing without compression. And what else? That's it.
I did suggest to Rhonda's family doc to actually check for May-Thurner syndrome as well. And I think that's when they did the ultrasound, they were looking for that.
Mm-hmm. But the May-Turners would typically be on the left side. I've never heard about that. I know because anatomically, when the arteries and the veins split in the pelvis, there's this funky crossover, and I think it's on the left side and not typically on the right, but you know, it looks like that may have been ruled out. Now you have already given us quite a good detailed, you know, clinical picture of what's going on. Now, in terms of compression, are you wearing anything right now?
Yes, I have a toe cap on and then a custom thigh high.
Mm-hmm. And is that controlling your leg pretty well, or you still feel like you're swelling into this?
No, I think it still swells, like it still goes up during the day.
Mm-hmm.
And it depends on what I'm doing. If I am on my feet a lot during the day, it's bigger than it was when I put it on in the morning.
Mm-hmm. Linda, did you measure her for that, or where did she get that?
I did. So we actually measured, and I did a bilateral comparison. I can send you the report if Rhonda's okay with that. So we started off and actually had a difference in one leg, left to right in 1,700 mils.
So this is a super, super interesting case in that I certainly the findings, whatever Rhonda was describing, is not consistent with your typical lymphedema. I think most of you or all of you already know that. So our first guess would be, what is the venous system like? Now, a May-Thurner syndrome would typically affect the left leg and not the right leg, but I just recently became aware of an article that you can have similar symptoms in the right leg depending on your circulatory system and how it may not be functioning all that well. I mean, it's a little bit like a blood clot, but a blood clot would be a DVT, a deep venous thrombosis would be occluding the vein from within. Here we have maybe some type of compression syndrome on the vein. Now, I think Rhonda is considering some more testing, but the testing would be past a Doppler ultrasound. It probably the next test she will have to do is a contrast MRI. Linda, do you know anything where Rhonda is with? And by the way, Linda is her therapist, so thank you for joining us on this call. Do you know where she is with arranging for some of that testing?
So she does have an appointment with her vascular surgeon. I believe it's in about 2 weeks. And so they're going to hopefully get more results at that point. They have done more ultrasound, ACT, kind of concluded that this might be a genetic disposition where her surgeon in Brandon actually remembers doing surgery on her dad and very politely says, "You've just got very bad genes." So it wasn't the best thing for her to hear at that point, but a part of something to consider. So at least we have a direction that we might be leaning towards to know where this is coming from.
Yeah, and the red flags that you want to consider is the leg shouldn't be filling that quick. It shouldn't turn bright red. That is not consistent with the diagnosis of lymphedema. And I think there's a test that you can do, a very easy test that's called a ruber of dependency. So where you have to keep the leg up for some time and then put it down. That could also rule out some arterial flow issues, because it would be interesting to do that ruber of dependency test where again you leave the leg very much up in the air for a minute or two, and then when you put it down it will not initially get red but quite red after a minute or so when the arteries open up. So it could be so many different things. A neurological issue needs to be ruled out, but you cannot settle, in this case, you cannot settle for an ultrasound that rules out DVT. The lucky thing, the good thing, I think, the learning experience for everyone here is compression is not contraindicated in her case, in this case. And that's where we're at right now. I want to ask Sophia first if she has received any questions for us.
I'm going to field the questions so Sophia can help answer them.
Sorry,
We're going to switch around a little.
We're just switcheroo.
Totally.
Yeah,
totally,
little switcheroo here. So we did up and asked a couple of questions. Have you looked at cardiac or renal issues? But, I'm interested as well. Was there an ABI done for this patient so that we can rule out, the contraindication for compression?
Yeah, so there was an ABI done. It came back normal, so that wasn't a concern. And that was when I first met her. I got all the doctor's reports faxed over, and again, no contraindication regarding compression in regards to the ABI results.
And when you have renal issues, renal failure, if you have congestive heart failure, if you have liver failure and you have edema from that, it would be very unlikely to give you a unilateral presentation. Right. It would then be bilateral, and it would still not explain the discoloration in her leg. So, Margie, any more questions?
Is there any lightheaded? Does she have any lightheadedness?
She does. So when she first came to, I did the volumetric measurement, and you could visibly see the legs swell up from the time she took her compression sock off, which would have been approximately 4 minutes that she was standing, and at what point she was getting lightheaded and had to sit down.
Does she wear any nighttime compression? That's another question that came through.
She's been very faithful with wrapping, with Comprolan compression wrap. And so just recently, last week, when I saw her for a follow-up, she got the Jobst Relax garment. So she was very excited about that. And so she's been wearing that. She did have her toes were still swelling up. So she decided to still wear her toe cap with the Relax garment.
Perfect. Sophia, you want to say something about the fitting that you guys have done?
Yes, absolutely. I'm just going to get Margie to share the presentation.
Absolutely. Yeah.
So once again, there's a lot of things we had to take into consideration for Rhonda with her occupation. She does travel quite a bit, and she is in a seated position. She is driving a lot. So as much as she needed a really high containing garment, we also wanted to make sure that she did have comfort and something that's really contouring. So here are the photos of Rhonda's leg. So as you can see, the reddening and then the foot area. So there's some really important areas that we really wanted to ensure that she had comfort, and we didn't have any bunching in the areas. So where you can see the arrows, so right at that popliteal fossa, we wanted to ensure that she didn't have the bunching or the coarseness of the fabric in that area. And then right at the foot too, you can see that she does have a little bit of ridging or a fold there. So we wanted to make sure that during that measuring procedure, we were able to get a nice a contoured fit, but we also wanted to ensure that we had enough resistance and containment in that area so it wouldn't have that fluctuating effect that she was experiencing. If you want to go to the next page there, Margie.
Absolutely.
So we measured Rhonda for lower extremity thigh high confidence garment. So this is our new fabric. So it's a contoured garment, very soft garment, but you're still getting a nice containment. So this was a perfect, really perfect mix for Rhonda, because we're still going to get that resistance that she needs, but she was going to get that comfort that she needs as well when she is working. Now, the things that I do want to point out, it's a little different than measuring for the Elverex. We do have a few different tension points, and as you can see here on the guide, the 0 indicates that we just have a body measurement. So you're not pulling any tension on that tape measure. And then as you can see, we have the addition marks or the plus, and that's going to indicate how much tension you're getting. So in the areas where there is a lot of flesh or you're not going over a joint, we're going to have you pull 2+ tension on those areas. So it's not very different. We're still having the same landmark. So we're just giving a little bit more tension in those areas, just so we have a little bit more of a contour, more fit for this patient. The other thing we did put in here as well is I put in the ankle comfort zone, and that is going to give a little bit more comfort in that area. We're going to have flexibility, so it's going to be right in where that Y or that instep area is. And then we also did a knee comfort zone as well, so just giving as much comfort to Rhonda as possible. And if you want to move to that next page, please.
Yeah.
The other thing we did is we made Elverex biker shorts. So we wanted to ensure, because Rhonda did have the occurrence of the genital edema, we wanted to ensure that we did have compression through the genital areas. We did a compression crotch, and then the compression garment was also made to hold the thigh high in place as well. So when she was quite active during work, the up and down motions this biker short would hold that thigh high in place. And then the next slide, please.
And just a quick note before you go on, Sophia, we are right at the end time here. So just a couple more minutes, guys.
Okay, perfect. And then we did a relaxed garment as well. So for nighttime, like Linda has mentioned, we did a relaxed garment. We were seeing a little bit of fluid accumulation in the toes. So we she decided to use one of her older stretched out Elverex toe caps to see if that could combat the edema throughout the night.
Is there anything, Linda, you want to add to the case?
Not at this point. I will be seeing Rhonda again in 2 days. So because we live quite a distance apart, she travels 2 hours to see me. So when we did the treatment phase, she actually just stayed at a hotel. So we were able to do it over a 2-week span and got a significant decrease in her Limix from 1,700, I think, down to approximately 400 after the 2-week treatment phase. So that was very exciting. And just to see the hope, like she said, she'd gone from to numerous appointments to numerous different healthcare professionals. And sadly, which is the case, I think, right across North America, is it's so underdiagnosed. So
yeah,
she was,
I think.
go ahead.
Oh, sorry. some of my bad habits kick in. Sorry for
worries.
interrupting.
No
But
worries.
no, this is true. I think it's one thing to, refer the patient with the diagnosis edema or lymphedema. But in her case, I think the key issue for Rhonda is to do some differential diagnosis, see where the culprit really is, because as much as compression is now indicated, that's the good thing. We are not doing anything that is maybe counterproductive. The compression is absolutely indicated, but it's also, we need to get to the bottom of it here a little bit more. And I appreciate you bringing her into this meeting, Linda. And I think, she would also be somebody, in fact, maybe 6 months from now, we should do a similar workshop with all of the patients and see where they're at that point. How about that, Margie?
I like that idea, Guenter. We'll have to
All
work
right.
on that one.
Hey, thank you everyone for this case. I want to move on. This next video is more like meant as a break, but it is a very teachable break. And full disclaimer, because we were now talking about the confidence garment for Rhonda, and Shanna, who is one of the Essity Jobst MAs in California, she was kind enough to share her experience with the confidence. So the full disclaimer is that she works for the company, and that actually Shanna and I, when we talked last week, we had a lot of fun. It was also an emotional discussion. We kept that part out, but I hope you enjoyed this learning experience. So Nicole, go ahead.
I trust you.
Sometimes I don't trust myself. What is it like to live with lipedema?
I think the hardest part about it is getting clothing that fits and that you can wear. As my lipedema has progressed, as my weight has gone up and down, I have more lobules in my hip area. And so it's really hard finding pants that will go over my hips. Nothing ever fits my waist. So I've kind of given up on that. And it's not like you can take the pants in to fit your waist, because then you can't get them up over your hips. I wear a lot of dresses. With compression leggings and non-compression leggings. And I find that is my lifestyle now. It's just dresses. COVID's been nice to me because I have lots of pajamas and I love pajamas. But yeah, so basically dresses and, living with it, going out to restaurants and even doctor's office and sitting in a chair, because I don't fit in chairs with arms, especially if they're solid on the side. If they have openings, sometimes I can slide in a little bit, but in restaurants, I have to ask for chairs that don't have arms. And I think those are the two hardest things. It's hard because I'm wide, but I'm actually thin. If you take me from the side, if you looked at me from the side, you would not know that I was as wide as I am. And I think that's the hard part, is just the judgment of people, and just living with it, and honestly trying to find clothes and to move. Getting moving with it and exercising is difficult. The fluid edema that's, that we think that's sitting around and stuff, that's similar to lymphedema. When I've had full body MLD and not had to go to the bathroom afterwards, which is something that I would assume if there's a lot of excess just fluids sitting around, that would happen. When I exercise and work out in the pool, I do have that. I do have an urgency to go to the restroom afterwards and stuff. So I think that's a little bit interesting that I don't have it with MLD, but I do have it when I work out. Yeah, I don't see it. I mean, I don't have swelling in my legs that's different, that goes up and down. It's pretty much the same all the time. I notice when my weight is down, the pain in my legs overall is better. I try to stick to a ketogenic diet, and I have found that the pain to touch on my legs and even wearing compression has gotten better by basically eating clean food.
And has compression made any difference in terms of pain perception?
Since I've worn 3 different kinds of compression stockings, or 4 different kinds, I think that our traditional Alvarex and a 20/30 compression was too much overall. I mean, I could wear it for only about 4 hours, and then it just started feeling too much pressure. The Alvarex Soft I could wear for about 6 hours, and then again then I really start feeling the compression levels of it. The Confidence, it's an all day thing. I'm very excited. I never ever thought I would be excited to say I can't wait for pantyhose. The knee highs are just amazing. I can put them on. I can wear them all day. So I can put them on at 9 o'clock in the morning and take them off at 9 o'clock at night and just not even know I have them on.
So how does it feel different? I mean, we know it feels different, but if you had to describe how it feels different, how would you describe that?
So I think with the Confidence, I put it on and it truly feels like a second skin. I don't feel it on my legs at all. And my knee highs have that soft fit band at the top compared to a silicone dot band. And I've always felt that silicone dot band because it does give a little bit more pressure. That soft fit band, my knee highs don't even move. And I was really worried about that because I did not think that they would stay up with the soft fit band, and they really do. I don't even know that they're on. And I think for me, that's the most amazing part of it.
Do you feel like you can be more active in it as opposed to the other types that you have tried?
Absolutely. I think that being active with the Confidence is just natural. You can do anything in them because that you don't even know that they're on. There's like no restriction. They just move with you and move with the muscle movement of your activity so easily. Again, I'm excited to see pantyhose, to see how that fits and that works. I only have knee highs.
From a Job's density point of view, how is the measuring different from a traditional Alvarex? Do you employ any other considerations there?
Yeah. So the measuring for the Confidence is definitely different than our traditional Alvarex. So our traditional Alvarex is very much done as a surface measurement up to the knee, and then tighter over our bigger muscle groups and stuff. And with the Confidence, we actually are going to give more tension to areas that we didn't before. So just above the ankle, we're going to give tension. We're going to also give tension over the calf, which is what we would normally do because it's a large muscle. No tension over the knee, definite tension in the mid thigh and the groin area to help hold that stocking up at a thigh level. It has been a little bit different measuring for the garments. It kind of takes you way outside the comfort zone, but it's been good. I've had some great success, and I'm really looking forward to everybody getting this and trying it because I really think it's a game changer.
So fresh, so new. Freedom. It's all for you. Freedom. Keep your ear to the ground. Talking about the freedom. It's the best show in town. Best show in town. Freedom. I'll give you freedom. Yes, it's right. Freedom. Start right now.
I love it so much. I just this garment just blows me away how comfortable it is and stuff. And I was talking to somebody yesterday and I was showing them the fabrics. I was showing them the Elverex Soft, and then the Confidence. And it's like, I have to tell you, for the past few years, the Elverex Soft was so soft for me. It was amazing compared to the traditional Elverex. And then I got the Confidence, and it is a whole new world for compression. The Confidence just changes everything. It's amazing.
So I hope you enjoyed this little fun project. It's definitely a first-hand testimonial. We didn't really prepare any time for questions, but I hope it brought it a little bit together. And maybe when you have a patient with lipedema, the diagnosis primarily being lipedema, that would be a good garment to try out with them. So we have 3 more cases. We're gonna have 3 more interesting cases. The next one is Linda. We have a short video. So Nicole, why don't you introduce us to Linda?
I first heard the word lymphedema after I had surgery for a suspected sarcoma above my knee on my left leg. It wasn't sarcoma. And after the surgery, the surgeon had a lot of trouble draining the site. There's a lot of fluid and I had a pump, but I was changing it every hour for a while. And so he sent me to a vascular surgeon, and she told me what lymphedema was and explained that I probably had it because of some undertreated or not treated cellulitis, which I've had a problem with. So she suggested I have MLD, and that was the first I'd heard of it. And so I sought out a certified massage therapist who I was with for about 1.5 years before I met Sarah. And so she's been so good to try to help me do some different things. I've had the MLD, but I also do some self-exercise at home. I try to do some MLD, and I looked up on the internet for exercises for people with lymphedema in their leg, and I wear foam under my wrap. And so that's what I've done to get this point.
Well, so Linda had already gone through some decongestion with her other lymphatic therapist. And so she was at a point where she was in more of a maintenance phase, but you could tell that the fibrosis in her tissue in particular was causing her some more frustrating complications. The weight of the swollen area and where it is just below the joint of the knee was really making it difficult to get any to reduce further, but also it was making the compression difficult because of being able to wear the compression products properly and consistently. And also, unless Linda was financially capable of coming very, very frequently, we had to find some other solutions that would provide her with more long-term benefit. I'm a big believer in independence and also quality of life living with lymphedema. So her and I started to explore some other methods that she could take advantage of to make her less reliant upon my therapy and more on things that she could be doing for herself. Linda is a very independent person and someone who I admire for her adaptability and her willingness to keep going regardless of how frustrating things are with her leg. So I really wanted to try to find ways to help her continue that. So the real challenging part right now is that Linda is getting recurrent skin breakage because of the fact that there's just so much weight in her leg that if it does swell a bit more, the skin's breaking down, and then she's either getting infections or again is not able to come see me because she's got open wounds. So that was one of the reasons that I thought perhaps speaking with you and being a part of this workshop might be of benefit, because there'll be lots of other brains that can either anecdotally or experience wise help us to find some other potential options for her. Linda has been doing self bandaging, and with me we've been utilizing more of the Ferro Wrap on the below the knee, because that's what we've been trying to address the most. So I have her wearing the channeled foam underneath the Ferro Wrap between the liner and the actual wraps themselves. And on her right leg, you are wearing a custom below the knee compression.
Yes.
Okay.
And
so
we're
is
using
that-
the Ferro Wrap strong. So we're in the 30 to 40 compression, just trying to be as aggressive as we can be to get that tissue to soften and let the lymph start flowing again in that area.
Well, on the up above my knee, where there is a large lump, for better name of anything else, that has the foam, and then I wrap a stretch bandage over it to keep it in place. So when I sit or when I'm walking, the foam is working on the lump. And I do some exercises for the lymph in my leg, and I when I'm not seeing Sarah, but every second day I do self MLD.
Could I ask you, what would be your kind of like in the perfect world, what would be your setup that you would want? What is your goal for getting the leg and the lymphedema under control?
My goal is to be able to walk more. It's hard to walk, and it's hard to get pants on that leg sometimes when I have the foam and the wrap. Not below the knee so much, but above the knee. It's hard to close. So I'm not as active as I'd want to be and as I always was. And Sarah was saying I was independent. I was always so independent. And now I depend on my husband to wrap my leg and to drive, because I always drove myself, but he drives. So I'm more dependent than I ever wanted to be. I'm 70 and I expect some slowing down, but I expected to be able to do more than I can do at 70.
So you can see where this case is dramatically different from Frankie's case. Frankie is strong, he has the endurance, he has the strength to put garments on. And I think in this case with Linda, we need to acknowledge that her skin is very sensitive. Pressure is good for her, but we need to consider, the shearing forces getting the garment on. And she has already worked with the Ferro Wrap on her lower leg. So Margie, are there any questions right now pertaining to the videos that we saw before we go into measuring considerations?
Let's see. There is a question. A friend has non-Hodgkin's lymphoma. I was advised that she can't get MLD, but is it possible to wear compression stockings or other garments?
Yeah, I think we would need a little bit more information. I mean, would she be doing this because she has swelling or because she wants to be proactive? I have not heard about a contraindication in that kind of like scenario for compression. I would think that the answer would be yes, she can wear compression, but again, we would need a little more information about the purpose of the compression. And I'm happy to answer that in an email if we have a follow-up, with that person.
Okay.
Now, I know Sarah and Sophia, we have tried already measuring Linda for a capri type leotard, and tell us a little bit about that experience.
So Sarah and I jumped on a video call, and we had Linda with us. We went through all the measuring, hoping for a successful garment. But the reality is that that garment didn't come back the way we really envisioned it. And then after having those conversations, we thought, and with you as well, Guenter, we discussed maybe we should have went about it a different way. So originally what we had measured Linda for was a capri type garment, so a fashion type of capri. And she would be utilizing her knee-high stocking on one leg and then the ferro wrap strong on the other. Now, when the garment did come back, we also provided a bib-like garment. So there was zippers on either side of the panty, and that would allow for the top of the panty to come down like a bib for ease of donning and for toileting. However, it just wasn't something that was manageable for Linda. And what we are thinking about doing next is a B to G garment, which would be like a thigh high that has no foot, and then having some zippers that go from B to D, or we had them up in the top that allow us for, we're able to really stuff the tissue into that garment. And then we would still be utilizing the ferro wrap and then the Elverex on the other side as well.
And yeah, I saw Sarah was on the call too. Are you still there?
Yep.
Any additions that you want to share with us?
So because of the tissue fragility around the knee, that's one of the big challenges that Linda and her husband had even trying to put the garment on. We had them try it yesterday when it arrived, and then they tried again this morning. But again, because of when I was listening to what was happening with Frankie, his tissue is, I think, a little bit healthier. So it was a little bit easier to kind of pick it up and mobilize it and put it into place. So Linda herself, as a seamstress, actually commented on the fact that perhaps some zippers might help with that, because they're very apprehensive about causing more tissue breakdown around the knee. She really enjoys wearing the below the knee compression on the opposite leg, so on that right side, which you can tell is shaped a little bit better too. So I think that's about all the extra things.
No, and I think in her case, in Linda's case, the compression, I mean, if you do a compression one, it's probably not going to hold anything significantly in because of what we said earlier, the pressure being somewhat adversely proportional to the radius. But she has good skin integrity on her thigh, on the upper thigh. And I know that people have maybe tried an adhesive lotion to keep the stocking on. You can certainly conceivably also think about a couple vertical strips of silicone, which I think in Linda's case, the thigh tissues are not the issue. They're more like there's more adipose tissue. And I think the skin integrity on the top part of her lower extremity is actually pretty good. So an adhesive lotion, but I know for some of you guys who are listening, I sound like a broken record when I say that the adhesive needs to sit on the skin for a couple minutes before it actually dries a little bit, because if you just roll it on and then reapply your garment, it will not work. And people have given up because of not applying it in the right way. So, but I think in hindsight, I want to also mention something about the obesity. In hindsight, I think the legging type to the groin will actually be a better option for her, because I'm wondering, she does carry a lot more weight in her belly than, of course, she would like and we would like. And now this is a disadvantage of doing this virtually, because my next question into the audience would be, how many people think that Linda should be losing weight? And I think that we will have probably 80% of hands going up. I would not put my hands up because I had this discussion, Sarah, you remember, we had that discussion with Linda. And when you have someone, she's 70, but when you have someone who is in her predicament and even like a little bit younger, you will always hear the same thing. Almost like 100% of the time, people will say, I've lost weight, but then I gained it all back. And when you ask them how many times that happened, and they try to think back how many times they have been to this through this experience from like either childhood or puberty until their mid 60s, 70s, they can't count it anymore. The issue, I think, with patients who are in this position that Linda is in, as much as we know, of course, if she lost 50 pounds, she would be more healthy, the garment would work a little bit better on her, but tell people, ask people to stabilize their weight and exercise as much as they can under the condition that they are in, because the last thing they need to hear is another weight loss recommendation and then feel like a year from now that they failed once more. And unfortunately, the truth is that a lot of women who have gone through the weight loss cycle there, when they regain the weight, they will disproportionately gain more weight on the lower half of their body. So I think what we are now trying with her is a capri type or legging type thigh high in conjunction with the ferro wrap that she already has. I think it was, I was part of it. I take myself into the equation. It was a little bit too ambitious to think that she would go into a waist high garment. But what do you guys think? I mean, Sophia and Margie help us out here too.
So we do have a couple of questions as well. And I think it's a good part of the garment discussion here. Sophia and Sarah, did you consider doing a full length ferro at all? Using the knee piece or the thigh piece?
So she can't have anything. One of her challenges is the skin infections and the skin breakdown happen in the popliteal space. She's also prone to yeast infections in around that area. So her reluctance and the constant infections make her not really willing to put something around that knee. And she did try a ferro wrap above the thigh before she came to see me, but found that she had more difficulty walking. And so she has been staying with using compression bandaging. So short stretch bandage and the foam padding underneath on above the knee instead.
And one of her main goals was to get out and really be more active, do more walking. And when she indicated that she found the ferro wrap to prevent her from doing that, that's kind of where we went with the Alvarex.
Okay. And I did want to, I know one of the questions also was, these garments didn't fit and that's really expensive for the patient. But I do want to point out with our custom garments, we do have 2 free remakes. So even though this one didn't work for this patient, we will make the changes at no charge. The patient won't have to pay for another set. These will be credited towards a different garment that would be more appropriate for her. So I know that's a big concern when people are trying to put somebody into a custom garment, that they're worried if it doesn't work out, oh my gosh, they're not going to be able to afford a second one. So I did want to address that question.
Us fitters appreciate that a lot, actually.
Yeah.
Yeah. No, and this is definitely a patient I think we should keep an eye on and follow up and hopefully, have a report back when we do this the next time. We'll do a little section on follow-up for patients. I know we have two more, and I'm now gonna say the same thing that they always say on television. You certainly don't want to miss the last one, because the last one is the cutest one of all. I have to say that. But we do one more before the last one, and that is Rose. So Nicole, would you cue up that video for us, and then we're gonna switch it to one more arm patient and then to the cutest one of the day.
Last February, my son was sick. During night, I think 10, 12 times, I tried to push him because he moved and he had fever. And around 3, 4 p.m., I understand I have a terrible new pain on my right arm. But I forget it. After a couple days, I understand that I can wear my coats. It's painful. And again and again and again, I tried to find my oncologist and I talked with her, and she told me I can see a little swelling, but for me, it's not visible. And she told me it's better to go to physiotherapy. And she gave me a list of these physiotherapies. But was same time then I start this COVID-19. And after one time, when I saw the physiotherapy, everywhere was closed for 2 months. And then again started to continue. Was a little late for me, but because I had really swelling, I was visible for every person. And 2 times per week, 3 times per week, I had massage up to last month.
Okay, so when you had the massage, were you also wrapped afterwards, bandaged?
Yes, she tried to wrap, but she asked me to close your fingers. When she wrapped me, I had a lots of pain on my bones here. And also, she asked me, "Is not good thing for sleeping. Please take it off before going to bed." And because of pain, I did usually maybe 5, 6 times. Just I have bandage during the night. And it means just when I saw her, I had 5, 6, 7 hours bandage. The rest I had sleep. And I tried to do with myself, but wasn't good because I'm not professional. And for example, here was a little, yeah.
Right.
And after, when I was very sad and I go to hospital, they told me Anne is professional. I didn't know why they didn't tell me before about Anne. And Anne started 2 weeks and a half with bandage. And this part is 2 centimeter better, but the problem is my arm was very, very hard all these 7, 8 months. And these 2 weeks started to be soft because I think my previous massage therapist tried to push this part because it was very big. And all this liquid, I don't know, whatever it is come down to this part. And for example, here, top of my hand, and this part, I had terrible swelling and also was very hard, doctor.
But now it's already getting better.
Yes, now it's soft and is slowly getting better.
She developed lymphedema in February of 2020, so a year now. And it was very soft pitting edema at the beginning. But of course, Canada went through the shutdown with COVID-19 in early March. She had started treatment at the end of February, only manual lymph drainage and no compression bandaging at that time. And I'm not sure, she was seeing another therapist, not myself. So I'm not sure how swollen her arm was at that point because I don't have the measurements from then. In July of 2020, she developed cellulitis and had to have oral antibiotics. Her arm is quite dense and thick in the forearm. The upper arm is actually quite soft with fairly good skin stretch. She is approximately 6 centimeters larger than her unaffected side, almost the entire way from the wrist all the way up. Her hand is a little bit swollen, very minimal, around a centimeter, centimeter and a half. But I already started bandaging her when I took these photos. So she had already been bandaged by me 2 times and had manual lymph drainage, and then started her exercise program. I think she's going to be in a class 2 just because of the density. And I think because of activity level as well. And she really does feel like her arm is more comfortable when she's bandaged, and she likes the support of the bandage. So she will probably tolerate the higher pressure.
Thank you, Nicole. And in this case, we don't have the therapist on the call here, but I think it is a good case to bring up, because in this case, I think the answer of what textile to use is pretty clear. In her case, I think it's clear. I don't know if Sophia is agreeing with me, but I think we are going with the traditional Alvarez, because in Rose's case, she really needs the containment. Does that make sense to you guys too?
Yes, absolutely it does.
And I think that Anne, her therapist, was not wrong to say that she benefits from a class 2. I'm always a little bit reluctant to recommend that right from the beginning, because people tend to do better when they're eased into the compression a little bit. But I think a class 2 is not out of the question for her. And then, you know, because the bulk of her edema is really here in the forearm area. I mean, conceivably, the glove could be a class 1 that runs all the way to the elbow. And I think she would benefit from an extended glove to the elbow, because that's what it looks to me when we saw this kind of like position.
Yes, I agree as well. And we, so right now this patient is not in a garment yet. She's going through the treatment, but once she does go through that treatment, that's definitely one of the products that we're going to suggest for her.
Cool. Now, Margie, before we switch into Peyton's case, were there any questions pertaining to the video?
Yes. Yeah, in fact, I was just taking a look there. So we do have a couple. Here's a question: when you do a class 2 sleeve, would you also do a class 2 glove, or is it too much?
Not necessarily, that entirely, and I should actually let Sophia also answer that question, but my take is, sorry for elbowing my way in here, but my take is that it's not necessarily a class 2 on the hand. It is really entirely up to the presentation of the edema. If there's more edema and more fibrosis, I want to say stubborn edema on the forearm, it could easily be a class 2 sleeve and a class 1 handpiece. That is not an unusual combination. But Sophia, chime in and tell me if you agree or not.
I absolutely agree. And then that's typical what we see. It's all really based on presentation and densities, how the edema is responding. So it's really going to be individualized, but most of the time that's what we're seeing.
Yeah. And there was one other question as well. Why are the bandages being removed at night?
Say again?
The bandages, why would you remove bandages at night?
Well, that is not part of phase 1 CDT. If you're looking at phase 1, which is what Rose is now going through, I guess for, I want to say almost like the second time, that would not be part of CDT. Unfortunately, people are modifying what is considered a traditional CDT protocol. And it's something that I didn't want to ask Rose because I don't think she knew why she would have had that advice given from her previous therapist. That is definitely not part of CDT. She should have, like she is now, wearing the bandages between session, and you can see she was on the way to or coming back from somewhere. She was in her car giving me that kind of like time. That would absolutely not be part of phase 1 CDT to remove the bandages at night or the next day. They stay on until the next session.
Yeah, and there was one other question that I thought should be addressed as well. So there was a question from someone asking about, with a class 1 glove and a class 2 sleeve, do we not worry about a tourniquet at the wrist? But that's
no, again, that depends on the presentation of the edema. First of all, the measurement here on the wrist has always been an issue for people, because if you had a person with a really small wrist, you don't want to take that measurement in the wrist crease. You want to take the measurements at the styloid process here, where that little bone is. Am I on the right side here? Where that little bone is, that's where you want to take that measurement. So you get a larger measurement because you're not necessarily measuring in the very smallest point of the wrist. And then you might even end up, tweaking that a little bit. If that measurement falls at 18.7, you may give it to 19. And your glove measurement can then again be a little bit looser over top. So if you measure for the glove circumference here, you can take the measurements that you take for the sleeve and add another 0.5 centimeters. I'm not talking inches. I'm talking centimeters, and actually get a nice transition. And then clinically speaking, and this is not typically something we recommend to the patients, but they figure it out on their own. Maybe by accident, they would put that glove on first and then put their sleeve on second. And then they realize, oh, this works much better for me because it gives me a better transition. That was not the intent when we measured the patient. That is not the intent of us to do, because, when the patient has a glove on second, they can take it off, wash their hands, put it back on more easily than wearing the glove underneath the sleeve. But for some people, that is a better solution, and I would just let them go with that. Does that make sense?
Absolutely. Absolutely.
Okay.
So it looks like we're coming up on our time that we should.
We are coming up on the time, and I think the reward for the people who have stuck with us all afternoon here, I know it's a long workshop, but we are in our final stretch. Nicole is already queuing up that last story, and by far the cutest video of the afternoon. So go ahead.
So when Peyton was born, it was like one of the first things that my husband noticed was, why is his hand so big? And so, initially, because he's got some pits behind his ears, we thought that he was stuck coming out. And so that was kind of our initial thought. And Dr. Margaret Perko is our primary care provider. And she kind of like let us, because I work in the NICU, so I'm around babies a lot. Like she knows I have a medical knowledge. And so we kind of were on the same page of like, okay, we'll let it, give it some time, because maybe it will be something that will resolve. And it didn't get worse. It didn't get better. He never seemed bothered by it. He still doesn't to this day. And so
not one bit
at all.
He's on the move.
He's a busy kid. And so, it always felt soft and everything. So there was nothing pressing that was like, we need to do something urgently kind of thing. And then I don't remember how I discovered it, but I noticed that he had a palpable lymph node in his axilla. And so we talked to Dr. Perko about that, and she was like, okay, let's get an ultrasound just to make sure that there's something there that we don't know. So we did that, and nothing big, just kind of, I think the radiology report, I think he was like 3 months old maybe 3 or 4 months old when we had this initial one. I think the radiologist report said something like an underlying infection. I think they quoted cat scratch fever or something like that. And I was like, definitely not. So we had that ultrasound and kind of just let it sit again for a little bit. And then we got referred to Ross Perko. They're siblings, conveniently. And he is our pediatric hematologist up in Duluth. So we saw him just kind of from, hey, what do you think is going on kind of deal. So Ross is really the one that ultimately ended up with us getting hooked up with Amy. And so Ross referred us also to Dr. Nancy Hutchinson, who is down at Courage Kenny in Minneapolis. And so it was a virtual visit, so she wasn't able to like touch, feel, that kind of thing with Peyton. And he was about 6 or 7 months old when we had that visit. And so then she referred us to do some PT. So we started therapy with Peyton in October. So he was like 9.5 months old or so. Then we got the correct sleeve, but then we couldn't get it on him. So we had to wait for the easy slide, which has been like my favorite thing. I use it to like put all of his clothes on.
It's like the greatest thing in the entire world, for sure.
So yeah, once we were able to actually get it on him, he has been wearing it. I think we started just with naps, just to make sure that it wasn't constricting anywhere, anything funky like that. And then he's pretty much been wearing it every night, and he sleeps for like 12 or 13 hours. So he's got it on for half the day. And yeah, and then when our babysitter nanny person is here, she naps with him or has him nap with it on. I don't. So he sometimes has it during the day for his naps and sometimes doesn't. But I mean, he's at least getting that 12, 13-hour chunk at nighttime. So it's definitely, for him, it's more in his hand, more from the wrist down. And then his middle finger is probably the one that's the most affected. And his arm itself is definitely fuller, but we just did measurements again with Amy yesterday, and I was thinking just now, actually, we should probably do his left side again.
Yeah, it would be good to compare his growth.
Yeah, because I mean, obviously he's 13 months old, like he's growing like a weed still. So
we've also been doing some physio touch, just because and he seems to tolerate, he's the moving target, so you get a little bit of a workout trying to keep up with him. But the concern we have is that the sleeve the relax is just great. Really, it's an amazing thing, and especially for him, for either nighttime or daytime, because it's padded, but it's not the thick tribute.
Yep.
It just seems that the hand part is just difficult to fit for him, and I'm not sure what the answer is. We've tried to do some modification with some neoprene wrap around there, try to make a gauntlet that would be safe for him to kind of just give a little bit of a squeeze through there. Just hasn't worked. But anyway, so anything that could help that, I mean, it wasn't recommended that we wrap, just because how would you do that?
Okay. I didn't overpromise, definitely a cutie, and I noticed he was wearing his Colorado shirt here for one of the pictures. So I think Katie, an awesome job on fitting him for the relaxed garment. I think this was the right thing to do. He is wearing it during the naps. Tell us a little bit about your decision making here in this case.
So when Amy reached out to me in regards to looking for some garment ideas, it just so happened I had just seen a 1-year-old for upper extremity like a couple weeks before, and had done a lot of research in regards to daytime use, and found that one of the big things is to avoid too much daytime garments, because it can hinder their development reaching for things, putting things in their mouth, all of that kind of stuff. So it was sort of trying to figure out what kind of a garment can help with the swelling, but also cannot impede any of his milestones since he's so young. We had discussed using a traditional nighttime garment like a Jovi pack, but then with how he presented, and there wasn't, a lot of like fibrosis, everything was very soft. And I was like, well, let's try the relax and see how it works. It's so soft that he could wear it for nap times. It's not super bulky. And so that was kind of where Amy and I got started. And then we were able to get him measured, which of course it's very challenging with a 1-year-old. They're, like Amy said, a moving target. But had to do an adjustment to the first one just for a length issue. But now that he's had the garment, it fits so well and is so easy for him to use. The donning was a very big issue, trying to stuff that very soft tissue, wiggly soft tissue into a garment. And luckily we have the REM products and that pediatric easy slide. So she got one of those for the arm, and she's not kidding. That video was amazing that she did. It really just slides on, and it was a big eye opener for a lot of peds patients that we see where it is difficult to get those garments on those squishy movie targets. So probably the next step is I'm seeing him again next week, and is to just kind of do some adjustments around that gauntlet to shrink down that hand area a little bit. And
Right.
Amy, if there's something you want to add on that.
Yeah, I think that having a little bit more compression at the hand would be great, but he tolerates the rest of the garment so well, and the family has just been so good at using both a manual lymph drainage and then wearing the sleeve at nighttime and as able during the naps. It's just been such a great compliment. I don't know, I am very pleased with the relax, and the size of it, especially for somebody so little. It just gives good compression, and even when he has it on in the clinic, just to try it on, he can move around. It doesn't hinder him at all. Like I said, he is a moving target, so it's been great. And if we could just get that hand part, the distal end, a little bit more compression or squeeze around the fingers and the hand. His long finger, his middle finger, seems to be the largest and has been the largest of all. Though it has come down in size since we started back last October in diameter. So that is a good thing, but we'd like to see the finger go down a bit more and the hand some more. So that would be really helpful.
Right. And I think at one point you will be able to wrap his little fingers. I mean, you and I know that the family will also go for a little bit more diagnostic work. And I just want to share for everybody, when you have a kid like Peyton, you always want to make sure that you rule out the presence of a lymphangioma, which is, it's a benign form of lymphatic dysplasia, if you will. And so that we are not fighting something that maybe needs to be addressed medically a little bit different than the pure lymphedema. Now, again, the family will go for some more diagnostic work, and it's similar than Rhonda's case. We haven't gotten to the bottom of her kind of like reason for having that red swollen leg. Luckily, in Peyton's case, the compression, even if it turns out to be a lymphangioma in his hand, the compression is not contraindicated. So you're still going to pursue compression to keep it in check, but there may be some additional medical treatments necessary. So that's one thing. And I think soon you will be able to wrap his digits. Have you tried with like a cohesive bandage that would stick to itself, but not necessarily stick to the skin, but stick to itself, like a Coban type bandage on his fingers?
We've tried a little bit, but because his fingers are so small, it's just really hard to contain. And certainly whatever we have done, it was only just during, a small window of time or during naps. We did try some padding with a neoprene kind of thumb wrap that extended, kind of a custom thing, just to kind of try to squeeze that hand a little bit, because the rest of the arm fits so well, and, didn't want to move any fluid proximal downward. But yeah, looking forward to when we could do something with a little bit more wrapping on the hand. Yeah.
I think you soon will be, and I think it was the right approach, and I would still continue with this approach for a little bit longer before he's fitted for, a longer compression garment for the daytime. Anything else you wanted to add, Amy, to the case?
I just think that, even though he's tiny, his family has been good, his mom, especially with doing the manual lymph drainage at home, and he's responded well. He tolerates it well. We have him on a raised mat kind of table, and he's on the move, but he tolerates it well. He plays and reads. His mom reads to him, and he's turning pages as we, do that whole process. We usually spend about an hour and a half, but not all of that is with manual lymph drainage, of course, because he's moving. But so I think that's a good thing and can be done from the get-go. It's just, it'd be nice to, any more recommendations on the compression bandaging or garments or
I think you need to, hold out a little bit. I know they have some more diagnostic work done soon.
Next week.
And then I think that you could soon start, again with the finger wrapping, individual wrapping. I would definitely stick to a more cohesive material so you can actually wrap the fingers separately and the hand maybe a little bit, and then still fit him into, this garment, and keep that procedure going for a little while. And then, when he's, 6 months older and then a year older from now, it will actually be different. It will get better in some ways, so awesome problem solving here. Sophia, do we have any questions for this little guy?
Yes. So is a diagnosis for lymphedema for Peyton different? Are the same diagnostic tests done for infants and neonates?
Well, that's the thing. I mean, you will probably not see it oftentimes until the child is born. And then I would still, just like the family, first of all, most families are surprised that there is lymphedema. And you always want to rule out that there is something more to it, like, is there multiple organ involvement, or is there an internal lymphatic dysplasia? And we had a very similar case many years ago. And it turned out that his name was Caden, and in Caden's case, he had a very substantial lymphangioma dysplasia, not only on his hand, but also internally. But some of that will come out as time goes. Right now, I think the family is absolutely on the right track. And luckily, he's developing very well. It's not like she hasn't complained, the mom hasn't complained to me about frequent diarrhea, or that he's not gaining weight, or all this stuff could also point to a much more extensive lymphatic dysplasia. I think right now you're on the right track again. Lymphangioma should be ruled out, and that could be with an MRI, or if the ultrasound technician knows what they're looking for, they can sometimes see it in the ultrasound. But if you don't do it specifically for that, it could be missed even if they had an ultrasound. So right now, I mean, personally, and to my disclaimer here is I'm not a physician, but I would not put him through any invasive lymphoscintigraphy or something like that, because I personally don't think it's warranted at this point. But
this one's for Katie. So when you measure a child, do you measure with a snug fit on bigger areas like you do in adults? So like in the muscle, more fleshy areas, would you still do a snug fit or more tension in that area, Katie?
So for this age and this size, I did well, Amy, we did it
We did.
telehealth wise, if you will. So it was a little bit of direction, but we concentrated on doing a surface measurement. And then probably one of the, and it was hard too, because, you know, he was swollen. Like the hand is something that we're working with to see if, you know, we may need to tug that more. But for sure, like with the hand area, because he was so much more swollen, when we take this circumference, we did, although we made the length at this area, we did take the circumference a little bit further back, so that it wasn't too tight around that area. You know, it's just like they say, smaller area, pull less. So with children, you just have to be really careful. The relax is a little stretchier than doing a traditional flat knit. Yeah, we did just full surface measurements, and then decided that because, you know, Jobst has such a great return policy, we could adjust if it came back and it was too loose somewhere or something like that.
Now, also, have you guys thought about using K-tape, or have you used K-tape for Peyton?
Yes, I can answer that. We did try that. His skin tolerated it. Okay, I was a little bit concerned. He had a little bit of a firmness just on his just proximal forearm. I have been doing a little bit of Graston with that, some soft tissue work, and that seemed to work better than the K-tape. So just saying, that doesn't mean we couldn't try it again, but for that time it was, yeah.
Thanks, Amy.
Yeah.
Now, how do rural CLTs get support with measurements for complicated cases like this? Do we do virtual consults or travel?
I think, you know, Margie or Katie.
You do both. Yes. You certainly can get help anytime you need it. We can help you virtually if we are unable to go, or if somebody's not in your immediate area. If somebody is close by, as long as the, you know, the situation permits it, many of the medical advisors can come in. Like I said, you know, with our first patient, Jordan, I went down back in May when COVID was still pretty bad here in Colorado, but, you know, Vicky was seeing Jordan, and, you know, we all wore masks, and I went in to help measure Jordan. So, but I know many of us have helped out virtually as well. So those can definitely be arranged.
For instance, Amy is 3 hours up north, so is Peyton, away from me, and we made it work. So we do the FaceTime, we do the Microsoft Teams, the Zoom, whatever we can do to help out virtually, we will try and do.
So impressive, really, the connection with you, Katie, and we have a local vendor, Kathy Heidi, but it's just so great, the response and just the help with and guidance with recommendations. So appreciate you and your team. So
now, just another question: how can, when utilizing something like a cohesive wrap, so something like our Compre 2, what's the best way to utilize it without restricting flow?
Well, I think it's, you know, you need to think where you're going to put it. In this case, you would cut small strips, you would pad out any like tiny creases. I mean, cutting and impeding circulation would happen maybe through the wrist crease, maybe through some creases at the fingers, because they have those baby creases, even like in his case, between maybe one digit and the hand. And you have to make sure that the product doesn't migrate into this. And so starting for, you know, with someone like Peyton, starting for a few hours, take it off, see what it's done.
Mm-hmm.
I would want to make sure that, you know, with the, let's say, kinesiotaping, and I know that's different, but with the kinesiotaping and stuff, you have to make sure that the skin is tolerating it. And you need to be able to make sure that the skin is tolerating those cohesive bandages too. But the ones that don't stick to the skin, but to the layers to each other, could definitely be used, so that that it would actually give you compression without having these, you know, multiple turns. When you do fingers on a grown-up, you always have these anchor turns and stuff, and that makes a hand in a child very, very bulky. But I think you need to cut small strips, you need to maybe pad a crease with a little bit of Artiflex or other types of padding material. It's not easy, but it can be done. And unfortunately, you have to redo it then again and again and again. And, you develop a little bit of a strategy for each child. Does it make sense to you, Amy?
Yes, it does. Take a little practice, but I can do putsy.
Right.
That's good.
Hey, unless you have something really pressing, Sophia? No?
No.
No. Okay. Hey, and I want to say that this was, the first virtual advanced compression workshop that I've done. I'm going to give the last word to Margie, but I want to thank you for having me and for allowing me to chime in here and there. It was certainly fun to talk to all of the patients that I've talked to. So Margie, I'm going to have you do the last word, and thanks for making this happen.
Well, I want to thank you. You obviously put so much work into this, and the videos with our patients. I want to thank all our panelists. Particularly sending those in and getting your patients to share their stories with us. I think it's such a great learning experience. I want to thank all of our team for all their help getting the word out on this. And I want to thank everybody. We still have over 400 people on here right now after 4 hours. So I know it was a long session. We hope you learned a lot. As Nicole mentioned in the beginning, we are going to get back to you and answer all those questions that we didn't get to answer on air. And I see Nicole, and I am going to give her the last word because Nicole has been behind the scenes making everything happen here. So thank you.
Well, thank you, Margie. I was just popping on to say thank you, everyone, for joining. This was such a great turnout. I was just blown away by the response that we've gotten. So Margie and Guenter, really, you guys get the credit. I just do the technical piece behind. But thank you, everyone, for joining. We are going to follow up with a follow-up email. I know we had quite a few questions that we didn't get to, so just be patient with us as we compile those. But we will send those out for you. And yeah, thank you so much for attending. Keep an eye out for future invites for future events.
Yeah, thank you, everybody. And I loved Guenter's idea about maybe following up on some of these patients so we can show their progress. And really, I do want to reach out to everybody and just ask you, if you have interesting cases, please reach out to myself or any of your medical advisors or sales reps with Jobst, and we would love to share these stories and continue this learning experience. So thank you all. Have a wonderful evening.